So just wanted to say one thing that regarding the talk and speakers, that the speakers who has been allotted like 30 minutes, they will try to finish in 20 minutes because of lack of time. The CV of the speaker will be displayed on the LED screen, and the chairperson will, what the chairpersons will do, the first chairperson will just summarize the topic, just give the introduction of the topic to be discussed by the speaker, and the second chairperson will just summarize. And only 2 questions per sessions are allowed to just avoid the time delay. So with these words, I will hand over mic to Dr. Devendu and Dr. Sudhir to conduct the PG quiz session. Thank you.
Thank you, sir, and welcome all delegates. I would like to say thanks to BDF organizing team for this annual conference. So this is the first session we are heading for quiz. It is for postgraduates, and we know teaching and learning never ends. So by preparing your questions for the quiz, we learn a lot. Dr. Sudhir and me learned a lot by preparing the quiz. So I invite Dr. Sudhir. So quiz is having six components, basically 6 components in SK, and every question has 10 marks. Okay, mic rakha hua, haan. So every question has 10 marks. No negative marking for all questions except pictorial round. In pictorial round, the question will pass on. In pictorial round, it is unique in the sense that it will pass on, and it carries negative marking too. So if team B is not able to answer, then C, then D, then E, negative marking will be -5. And if suppose in the picture round, they are not able to answer, they have positive 10 marks. If it goes to them, the positive marks will be 5. They will get 5 marks only. But if they give the wrong answer, you will get -5. -5 for them, -5 for them. माइनस बराबर ही है, लेकिन जो प्लस मिलेगा वो आधा हो जाएगा. ठीक है, गॉट इट. ठीक है, और बाकी जो नॉर्मल क्वेश्चन है पिक्टोरियल राउंड के अलावा जो क्वेश्चंस हैं उसमें देयर इज नो नेगेटिव मार्किंग एंड दैट दोज विल नॉट पास ऑन. सो इफ इट इज फॉर टीम ए, टीम बी, तो इट इज फॉर टीम बी. इट इज यू कैंट गिव आंसर. if at all you give answer, you will not get any point, है ना. So sir, I invite
cash prizes, first prize is 10,000, second is 7,000, third is 5,000.
So Dr. Kunal has informed me very beautiful thing. We should all energized with that first prize is announced to be 10,000, second is 7,000, and third is 5,000. Sir, quiz conductor को भी एक Thank you. Dr. Sudhir, please come. हाँ सर, शुरुआत में कॉफी. ये भी ठीक है.
टीम जो है ना, टीम ए एब्सेंट है, तो मार्किंग उस हिसाब से कीजिएगा.
हाँ, मैं वो गायब कर दूँगा, मैं बीसी करूँ.
So first of all, I would like to invite all the participants to introduce yourself. Kindly give the mic to all the participants. Please introduce yourself. One by one.
जल्दी जल्दी इंट्रोड्यूस कर दे.
Start from team B. Team A is absent, so team B is from AIMS, Patna.
My name is Dr. Zarem Liachankul. I'm doing PG in emergency medicine, AIMS Patna.
Okay.
Myself, Dr. Ajay, PG1 in AIMS Patna, emergency medicine.
So clap for everyone. Next, team C. Okay.
Dr. Gunjan from IGMS Patna.
बोलो बोलो, तेज आवाज है, अब तो कोई नहीं। बस उसमें क्या है? वेरी गुड। पीएमसी को
Okay, so we have total 6 teams, 3 from PMCH, 2 from AIMS Patna and 1 from IGMS. So we will start with the first pictorial round, and
it will flash for 45 seconds only. So you will get only 45 seconds. So उसके बाद कोई टाइम नहीं मिलेगा, उतने में तक आंसर देना है। पास पिक्टोरियल में पास होगा, पिक्टोरियल में लाइन से पास होगा, ऐसे नहीं कि आप दे सकते हो। स्टार्ट बी से होगा एंड इट विल पास सीरियली।
okay, so this question for team B. And this pictorial round is related with the persons who are either have developed the insulin molecule or had any relationship with the insulin molecule.
It will speak
So
out.
identify him.
Benting. Patrick Benting.
Banting.
Correct answer. So full marks. Next question for team C. So he is Sir Frederick Banting, who was given Nobel Prize for discovery of insulin along with MacLeod. Team C. Wrong answer will,
-5.
and if you are not able to
If you want to
answer,
pass,
you can
then pass it.
pass on.
Pass. C. D.
Charles Best.
Charles Best.
Is Leonard Thompson. He is the first patient to receive insulin. So -5 for team D. So the next question is for team D.
Team B.
D.
D. हाँ, you will get 0. They will get -5.
Team D.
Charles Best.
Charles Best.
He is James
Oh,
Collins.
pass और नहीं किया आपने।
He is James Collins, and he is related with the insulin development, and he basically purifies the insulin. So the question for the next team, team
E.
E. Pass. Next.
MacLeod.
Okay. Right answer is John MacLeod, who was given Nobel Prize along with Banting. Next question for team
F.
F.
Team F.
Who is she?
Pass. Next team.
Next team.
Want to attempt? No.
Pass.
You want to attempt? No. You want to attempt? You want to attempt? No one want to attempt.
Okay.
Okay.
She is Professor Dorothy Hodgkin, and she won the Nobel Prize for describing the 3D structure of the insulin. So next question, last question of
For
this round.
G. For team G. You want to attempt it? No? Sanger.
Correct. Very correct. Is Frederick Sanger, who received two Nobel Prize, first in 1958 and then in 1980, both for sequencing, first for the sequencing insulin and second one is for the sequencing this nucleic acid. So after this round, the score is?
So the score is team B is 15. Is heading it. Then team C is 0. Team D is -10. अभी घबराने की कोई ज़रूरत नहीं है. There are many more rounds. Okay. Team E is again 0. Team F is 5. Team G is 0. Okay.
Okay. So the next round is related to epidemiology, and the correct answer will
Give
achieve
10 marks.
10
no
marks.
negative marking, and it will not pass on.
No, not pass on. So first question from team B. Based on the current trends, the idea projects that by 2045, dash million individual will have the diabetes. By 2045, what is the projection as per idea?
So no negative marking.
Option A, sir.
Option
A.
A.
642.
So tell the question, answer also.
642 million individuals.
So the answer is B, 783 million. Actually, it was revised in 2021, and drastically number has been increased. So the next question from
For team
team C. Highest percentage of age-adjusted comparative prevalence of diabetes is found in which country, as per the latest IDF report? Highest prevalence of diabetes. No negative marking.
India.
Wrong answer. It is our neighboring country, that is Pakistan. So the next question from team D. In 2021, the prevalence of diabetes in individual aged 20 to 79 years worldwide was. What was the prevalence of diabetes? No negative marking.
11.3.
Wrong answer. It is 9.8. So next team, next question. The total cases of diabetes in adults in India as per IDF 2021.
Team E. 68 million. Answer B.
Answer
B.
B. Wrong answer. It is answer A, 77 million. So next question for next team. The global prevalence of GDM as per IDF 2021 is. The global prevalence of GDM.
17.1.
17.1, very near, but wrong answer. It is 16.7. So the last question of this round for next team. The global proportion of people with undiagnosed diabetes. कितना percentage लोग undiagnosed हैं globally?
Last question रहेगा ना इसका.
There is no negative marking, so you can answer.
$44.7.
44.7. Right answer.
Good.
So right guess. So we will move to next round, round 3, and before moving, that
टोटल
Score
इस राउंड में सर आपके क्वेश्चन बहुत टफ थे, सारे बच्चों ने 0 पाए, बस एक टीम जी को छोड़ के। बच्चों को कॉफ़ी पिलाओ भैया।
स्कोर बताएंगे?
हाँ, स्कोर इट इज टीम बी इज 15, टीम सी 0, टीम डी -10, ई 0, एफ 5 एंड जी 10।
So we'll move to next round, and this round is related to different types of diabetes. And the first question is for team B. Raised blood glucose is feature of all except
Option A, hypothyroidism.
hypothyroidism. Correct answer. So full marks. Next question for team C. As per ADA, women who had GDM should be screened for type 2 diabetes at least every how many years?
One year.
It is 1 to 3 years, so at least 3 years. The answer will be at least 3 years. As per ADA, it's written 1 to 3 years. So, next question for the next team. A beta system of distinguishing ketone prone diabetes is based on. So here you have to say A beta stands for. It is ketone prone diabetes. A.
A.
Right answer.
Very good.
So, next question for team E. True statements about GCK Modi is glucokinase, maturity onset, diabetes in young. Which one is the true statement?
टाइम इज रनिंग आउट, जल्दी जल्दी बताओ। बी.
B. May require treatment only during pregnancy. Correct answer.
गुड.
So, next question for team
एफ.
F. Honeymoon phase is seen in type 1 diabetes. Correct answer.
कलीग्स भी तालियां बजा सकते हैं।
And last question of this round. Genetic syndrome not associated with diabetes. Which one? D. Fanconi-Bickel syndrome. Correct answer.
करेक्ट. गुड.
Actually, Fanconi-Bickel syndrome is associated with hypoglycemia.
दिस इज द एंड ओनली.
So,
दिस इज द एंड ऑफ थर्ड
answer,
राउंड.
score is
Score is 25 team B, team C again 0, team D make it from -2, it comes to the surface 0. Now team E is 10, team F is 15, team G is 20.
so. We'll move to the next round, that is round related to complications of diabetes. And the first question is for team B. Whipple's triad is used for the diagnosis of hypoglycemia. Correct answer. ताली बजनी चाहिए, है ना?
हाँ, ताली नहीं बजने के भी -5 कर देते हैं और जिसकी ज़्यादा ताली बजेगी उसके +10.
So next question for team C. Which cranial nerve involvement is most commonly seen in diabetic mononeuropathy?
A, second cranial nerve.
So it's wrong answer. If anyone from the audience want to tell. Which one?
Third.
Very good, sir.
नहीं बच्चों ने ही बोला third.
So next question from team D. The first defense against hypoglycemia is. There is no negative marking, so
fast.
you can answer.
टाइम जा रहा है. नहीं सर ऐसे प्रॉब्लम मत कीजिए. मार्किंग है सर. Increase epinephrine.
Wrong answer. Very good. Decrease insulin level is the first defense.
बच्चों को हाइपोग्लाइसीमिया हो रहा है सर.
So next question. All are risk factor for hypoglycemia except. All are known risk factor of hypoglycemia except.
फास्ट इजी वन है तो. ए पक्का लॉक कर दें. कड़क कर दें लॉक. ए
A is known risk factor. Answer is D, short duration of diabetes. The longer the duration of diabetes, the chances of hypoglycemia is more. And the next question, referral for transplant evaluation should be made when the GFR approaches in diabetic kidney disease. What is the baseline GFR?
आंसर सी.
Which one?
सी.
C. C is wrong answer. It is answer A, 20 ml per minute per 1.73 meter square. So next question, last question. The DCCT, this trial, diabetes control trial, demonstrated that improvement of glycemic control leads to reduction of complication. Numerically, which diabetic related complication is reduced more as per this study? कौन सा कॉम्प्लिकेशन सबसे ज़्यादा रिड्यूस हुआ था?
थोड़ा फास्ट. टाइम इज गोइंग. फास्ट. Albuminuria. D.
Wrong answer. It is diabetic neuropathy. So after this round, we will like to know the score.
So after fourth round, it is 35 for team B, still 0 for team C. 0 for team D, 10 for team E, 15 for team F, and 20 for team G.
So next round is round related to management of diabetes. And the first question is from team B. Teplizumab is recently approved by US FDA for अभी मोनोक्लोनल एंटीबॉडी का ज़माना है, तो डायबिटीज मैनेजमेंट में भी मोनोक्लोनल एंटीबॉडी ये रिसेंट मेडिसिन है, आपको जानना भी चाहिए.
Sir,
Yes.
C.
Option C. Delay in the onset of type 1 diabetes. Right answer. So this one is the right answer. Actually, this
अब टीम
teplizumab
जरा तेजी से
molecule is
मार्क्स नहीं मिलने वाले.
this molecule is anti-CD3 molecule,
कॉफी आ गई.
and it acts in it's given in stage 2 of the type 1 diabetes.
For team C,
So this question is from team C. The false statement regarding GDM treatment is, which one is the false statement?
ये भी तो इजी वन है. जल्दी बताओ. ऑप्शन सी. पक्का?
Option C.
सोच लो. लॉक कर दें? चलिए सर लॉक कर दीजिए, बच्चे कह रहे तो.
Option C बोला आपने. So it's a wrong answer. The correct answer is option D.
What two medicines we can give in, what two OHs we can give in GDM? मतलब दे सकते हैं, मतलब वो वाली बात है ना. तो फिर नॉट कंट्राइंडिकेटेड था ना, आपको पता ही है. फिर क्यों गलत किया?
So next question is from team D. Macular edema is a side effect of which oral anti-diabetic drug?
कौन सा? विल्डाग्लिप्टिन.
Wrong answer. Well tried. Anyone? Pioglitazone. Pioglitazone is the culprit medicine. Next question for team E. In 2007, the first of a new type of type 2 diabetes medication called GLP-1 became available. Which of these ingredients did it contain? जब पहली बार 2007 में GLP-1 एक्सट्रैक्ट हुआ था, तो कौन सा इसमें इंग्रेडिएंट था?
बताओ. हाँ, लिजर्ड वेनम.
Very good. Correct answer. So, we are moving to next team. Which of these drug is weight neutral?
DPP-4.
DPP-4 inhibitor.
लॉक कर दें?
Correct answer. And the last question For next team, angioedema is a side effect commonly associated with the use of angioedema.
Team G. बताओ बच्चों. Option C.
Pioglitazone, wrong answer. It is DPP-4 inhibitors. So angioedema is a known complication of DPP-4 inhibitors. So this question is from the audience. Which SGLT2 inhibitor is having highest selectivity for the type 2 receptor over type 1 receptor?
जिसको आता है वो हैंड रेज करे बच्चों में से. तुमको पता है? नहीं तो हमारे बहुत सारे एक्सपर्ट पीछे हैं, उसके बारे में एक नहीं दो चार बातें और बताएंगे. सोटाग्लिप्लोजिन.
It is sotagliflozin.
Empagliflozin, yes.
Empagliflozin is the correct answer, and sotagliflozin having the lowest one. So we move to the last round.
So it is again the pictorial round.
Again the same
It
negative
is
marking
again
and pass
pictorial
on.
round. So it will pass on to, ठीक है, और negative carries the negative marking. So by the end of the fifth round, it is 45 for team B, 0 for team C, 0 for team D, 20 for team E, 25 for team F, and 20 for team G.
शुरू करें आप. टीम बी, फर्स्ट क्वेश्चन. इसको आइडेंटिफाई कीजिए, कौन सा क्लिनिकल कंडीशन है.
बहुत ब्राइट आ रहा है, बहुत ब्राइट आ रहा है. मतलब अगर सही से बहुत ये है, ये चीज़ है.
तो पास ऑन भी कर सकते हैं.
नेक्रोबायोसिस लाइपोइडिका डायबिटिकरम.
करेक्ट आंसर. इट इज डायबिटिकोरम नेक्रोबायोसिस लाइपोइडिका. गुड. सो next question for team C. Identify the condition.
बहुत ब्राइट आ
You
रहा
can compare the both thigh.
है. बहुत था ही है, बहुत मुश्किल आ रहा है. किस कंडीशन में होता है डायबिटीज में ऐसा, किस में?
एक हिंट मैं दे देता हूँ. इट इज ए वेरी पेनफुल कंडीशन.
लो, पेनफुल है, प्रॉक्सिमल है. इफ यू वांट टू पास इट क्योंकि टाइम हो गया तुम्हारा. नेक्स्ट टीम. नो, यू हैव टू बी रियली फास्ट. नेक्स्ट टीम. नेगेटिव मार्किंग है. हाँ, डायबिटिक न्यूरोपैथी.
डायबिटिक न्यूरोपैथी मतलब कि जो आंसर है डायबिटिक न्यूरोपैथी में बहुत.
अभी मत बताइए, अभी ट्रांसफर कर दीजिए.
नेक्स्ट.
नेक्स्ट, एमायोट्रॉफी.
करेक्ट आंसर. इट्स डायबिटिक एमायोट्रोफी. इट्स a type of diabetic neuropathy only, but diabetic neuropathy is not the. So it was diabetic amyotrophy. So this question for next team, team D.
टीम डी. हाँ,
Name this sign. What is the name of this sign?
Please make it fast. Pass. Next team. Next team. Sign का नाम. Prayer sign या
Prayer sign. Good. Correct answer. It is prayer sign related to diabetes, stiff hand syndrome or chiroarthropathy. So, next question. What is this instrument? This
From team E.
instrument का नाम बताओ.
कॉमन चीज़ है ये. नाम सुना होगा. नाम तो सुना ही होगा. देखा हो ना देखा हो.
और ये वार्ड में पोस्ट ग्रेजुएट स्टूडेंट को कैरी करना चाहिए. डायबिटिक पेशेंट इतने सारे एडमिट होते हैं तो अपने पास रखना चाहिए. जो किट है उसमें होना चाहिए.
हाँ. Fast. Pass. You are passing it, okay. Monofilament.
पूरा बताओ. 10 gram monofilament which is used. Okay. So, next question. What is this condition? Name this condition. क्या बोल रहे हैं?
Malignant otitis externa.
Correct answer. And the culprit bacteria is Pseudomonas. Good. So, the last question is from team F.
G.
G. Team G. Identify the condition. एक हिंट दे देता हूँ. इट्स नॉट an infective condition. Not an infective condition. The time is up.
बोलो सही से बोलो. Granuloma annulare.
Wrong answer. Next team. It is passed to team B.
Want
Not
to
able to
attempt?
answer, then you can pass to next team.
Want to attempt? कुछ दिखाई दे रहा है इसमें. कुछ दिखाई तो दे ही रहा है ना. Arterial ulcers. नहीं. कोई नहीं है सर, आप ही बता दीजिए अब तो.
So the answer is diabetic bulla. So that's the end of all 6 rounds. The final score, Dr. Dibyendu.
अरे सर. So team B is 55, team C is 0, team D is still 0, team E 20, Team F scored, they take more points in this round. They get 55 again, and Team G is 20. So is the answer. So एक राउंड क्लैप का हमारे लिए भी हो जाए. थैंक यू. आप इसको अनाउंस करने के लिए रिजल्ट. किस में सर? बताओ 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 बताओ. सर राइट आंसर है क्या? आपका आंसर आपका आंसर आपका क्वेश्चन है सर, ये वैस्कुलर है कि न्यूरोपैथिक है? फ्रॉम दैट पिक्चर. नहीं.
It is
थैंक यू सर. ये वाला ट्रैक, विच ट्रैक? मोनोफिलामेंट से जो चेक करते हैं वो कौन सा ट्रैक चेक करते हैं, कौन सा सेंसरी पाथवे चेक करते हैं? डॉर्सल कॉलम. सर विल गिव यू अ चॉकलेट. तो एक्सपर्ट का होने का फायदा होता है हमेशा. तो क्लैप करो यार सर के लिए, ऐसे मत करो.
एक करके टीम को बुलाते हैं और
हाँ.
हम लोग सम्मानित करेंगे.
कहाँ है डॉक्टर? वो कहाँ गए? कुणाल, डॉक्टर कुणाल. सो सर रिजल्ट आउट आप करेंगे, आप कर दीजिए रिजल्ट. मतलब हाँ सेकंड थर्ड बस ऐसे बता दीजिए.
करके बुला करके सब लोग को सर्टिफिकेट और जो देना
सर्टिफिकेट बना हुआ है? I don't think so. हाँ मतलब क्या करें सर, मतलब अभी अनाउंस कर दें सर. मतलब नहीं ठीक है सर, तो कोई बात नहीं, तो ले ही लेंगे आप.
सर्टिफिकेट है ना. हाँ तो सर्टिफिकेट हम लोग देते जाते हैं, बैठाते जाते हैं.
और सर को बुला लीजिए.
फर्स्ट टीम को पहले बुला लो, है ना.
हाँ.
ऐसे करके
So for the first team, this is a tie between the team B and team F.
टाई अप है.
हाँ तो टाई अप है. कुछ क्वेश्चन देना है सर?
हाँ तो क्वेश्चन दे सकते हैं.
तो फिर आइए भैया, टीम B
क्या
and team
टाई
F.
अप में क्या करना है? एक
सर नहीं सर बताएंगे, संतोष सर भी लास्ट. सर आपका एक मास्टर क्वेश्चन तो चाहिए हमें. आइए आइए. नहीं सर, एक क्वेश्चन तो आपकी तरफ से प्लीज 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 प्लीज.
एक क्वेश्चन हम लोग और ट्राई कर सकते हैं, टाई अप अगर हो गया तो.
हाँ सर, या तो ये कर लीजिए.
ठीक. So, what is this lesion?
दोनों फिट है, दोनों.
Okay, identify this condition. Emphysematous?
गॉल ब्लैडर. बड़ा मुश्किल हो रहा है सर. और कौन सा कर सकते हैं? अच्छा तो थैंक्स
है और है.
हाँ रुक जाओ, अभी सर के पटारे में बहुत कुछ है. वी विल डिफरेंशिएट फर्स्ट एंड टू. इधर आ रहे हैं सर क्वेश्चंस. ऐसे सर क्वेश्चन पूछे सर, आप मुझे क्वेश्चन पूछिए सर, आपके बिना नहीं हो पाएगा सर, वो आउट ऑफ द ब्लू वाले क्वेश्चन आप ही बता पाएंगे सर। एक क्वेश्चन पूछिए सर जो बता पाए, आइए सर। हाँ टाई को, हाँ वो तो करना पड़ेगा।
जो पहले हैंड रेज करेगा उसी को बता।
हाँ हैंड रेज करना है पहले, बोलिए।
लेकिन अगर हैंड रेज पहले करेंगे और गलत जवाब देंगे तो वो ऑटोमेटिकली
सेकंड होगा।
सेकंड पोजीशन पर।
Types of type 1 diabetes? How many types? And what's the difference between the two? Genetic and environmental. And what about autoimmunity? How do you diagnose type 1A? So which gene you check for type 1A? To segregate in routine clinical practice, what test you do to know about whether it is type 1 or type 2 in clinical practice? So that will give the answer. So that is GAD65 she said, so it is the autoimmune markers. So type A is linked with autoimmunity, B is the idiopathic one where you have evidence of beta cell destruction, where you can have significant C-peptide diminution. Anybody can guess for extra prize money? Any idea about 1C? And this is for all of us. Type 1C. Type 1C. It's for all. And for the seniors, they have to give the extra to the PGs. Okay, type 1C is a fulminant type of type 1, which is prevalent in Japanese. And you have a normal HbA1c. It is so rapid that the HbA1c may not be raised, unlike type 1A and B. And you don't have evidence of autoimmunity also. So it is like B, but very rapid course. And 1C, more prevalent in Japanese. So thank you. अभी पूछना है?
सर
फैसला नहीं हो पाया।
तो अभी फैसला नहीं है, दोनों जीरो पे रहा. ओके, चलो सिंपल वन.
बस टीम एफ को और बी को रिस्पॉन्ड करना है।
सुधीर.
Which renal tubular acidosis is commonly associated with diabetic nephropathy?
चलो दोनों हो गया. अच्छा चलिए. फर्स्ट टॉक किस चीज का था हम लोगों का? फर्स्ट टॉक वेद का है ना?
सर कुछ
3G का है. ओके.
वीकनेस के बारे में पूछ लीजिए कुछ।
The three hormones which are impacted by the triagonist, the three hormones which are impacted by the triagonist, which are now in vogue in the management of type 2 diabetes. Any idea about triagonist? Dual agonist? Stepping
agonist
way forward from GLP-1. So dual agonist will be GLP-1 and? No. GLP-1 and the second one? GIP. So ये भी tie हुआ. And what is for the triagonist? Triagonist जल्दी बोलो, फिर let us decide. We are getting late or Haq Sahab is getting restless. The other hormone, okay, it is there in the defense mechanism of hypoglycemia. चलो जोर से बोलो, डिसाइडिंग फैक्टर है ये.
बोलो, हाथ खड़ा करके उठ करके बोलो आराम से.
टाई जिसमें था एक आदमी बोलो. डिफेंस मैकेनिज्म. अभी तो आया था उधर से आंसर, इट इज ग्लूकागॉन. सो ये भी नेगेटिव रहा. क्या किया जाए? सिंपल वन.
हम ले जाते हैं प्राइस.
प्री प्रो
Simple one.
इंसुलिन में कितने अमीनो एसिड होते हैं? प्री प्रो इंसुलिन, रॉन्ग आंसर.
चलिए ये तो ऐसे
इट
ही.
इज 110. प्रो इंसुलिन में 86 होता है, प्री प्रो में 110 होता
तो ये भी नहीं मिलेगा किसी
है.
को.
हो गया.
हो गया.
ये फर्स्ट हो गया, वो सेकंड
ये
हो
नहीं
गया.
जवाब दिया तो
चुप रहे.
चलिए चलिए, बेस्ट विशेस फॉर अ ब्राइट फ्यूचर. थैंक यू.
कुछ है?
बुला करके
सर सर्टिफिकेट है? ठीक है, तो फिर क्लोज कर दें सर. सो
सर एक ग्रुप फोटोग्राफ सर ऊपर रहा. अरे
so all the team please come to the stage. सर आ जाइए ऊपर. हक सर आइए. चलिए सर, हम लोग हम हाँ चलिए जहाँ भी रहिए सर. इसके सिंह सर को बुलाइए. कहाँ गए? इसको देख. जी सर.
जब इतना ग्रुप पूरा सबको आ जाए, जितना आ सकता है आ जाओ. आ जाओ. यार स्टेज नहीं टूट जाए.
अच्छा. थैंक यू.
So we'll be distributing the. आप आ जाइए सर, आप आ जाइए ना. फर्स्ट प्राइज, सेकंड प्राइज, थर्ड प्राइज. हाँ हाँ हाँ.
Third prize goes to Team G. from PMCH, Dr.
Third
Deepshika
prize.
and Dr. Neha.
आया कुणाल पैसा तुम लिए हो सब आगे ना
For second prize, it is team F, Dr. Iqbal and Dr. Jainul
आए आए आप साहब
from AIMS Patna. And the winner is team B, Dr. Jairam and Dr. Ajay from AIMS Patna.
साथ साथ गिन भी रहा है कहीं कम तो नहीं है
Thank you, sir. Thank you, H.K. Singh, sir, Santosh, sir. Thank you, Dr. Devendu, for such a nice quiz. It was very learning experience for all of us. So now we'll be starting our academic sessions, and the first session is a very interesting session which will be given by Dr. Ved Prakash, and to chair the session may I call upon Dr. Surendra Kumar sir and Dr. Vijay Achari sir to come on the dais. Sir. So Vijay Achari sir and Dr. Surendra Kumar sir.
Hello.
A very good morning to all of you. We are starting an interesting session, 3 Gs and dysglycemia. I mean, for some of you, this term might sound unfamiliar, but it has been there since diabetes was discovered. Basically, these are related to hormones that may antagonize actually do antagonize the action of insulin at the physiological level, and that is how glucose homeostasis is maintained, and also at the pharmacological level with their adverse effects. To elaborate more on the subject, I invite Dr. Ved Prakash, a distinguished faculty from IGIMS, Patna, to speak on the subject.
Thank you, respected chairpersons. First of all, I would like to thank the organizers, especially Santosh sir, for this opportunity. And Also, I would like to congratulate Dr. Sudhir and Dr. Divendu for a very nice quiz conducted by them. It's really interesting and very nice. So topic given to me is 3G and dysglycemia. It is a very interesting topic, and it's actually covers at the physiology level, pathology level, and also at the treatment level. So basically, glucose in human body is derived from three sources. First is the exogenous glucose, which we take by food, mainly in the form of polysaccharide converted into the oligo, disaccharide, monosaccharide, and finally monosaccharide absorbs from the gastrointestinal tract. That is the exogenous source of the glucose. Besides this exogenous source, there is also endogenous production of the glucose inside the body, and the process for this endogenous glucose production is mainly glycogenolysis and gluconeogenesis. Glycogenolysis means breakdown of glycogen into the glucose, and gluconeogenesis means synthesis of glucose from the non-carbohydrate source, and mainly from lactate, pyruvate, and amino acids like alanine, glutamine, and also from the glycerol. And why glucose is important? Because glucose is the sole metabolic fuel for the brain. Brain can only use glucose in the normal conditions or even in the early fasting states. And for the proper functioning of the brain, glucose is must. So glucose should be maintained within a very tight, within the normal range, known as the glucose homeostasis. Further, so basically systemic glucose balance is maintained by glucose influx into the circulation and glucose efflux out of the circulation. As I have already discussed, glucose influx is mainly by exogenous glucose and endogenous glucose, and glucose efflux is by brain glucose utilization and other glucose utilization by the other organs like muscles, fat, liver, and kidney. So a tight balance exists in the human body to maintain glucose level within the normal range. So overall, if we see the glucose pool in the body, free glucose pool in the extracellular fluid and in cells, only 15 to 20 gram of glucose is available in the extracellular fluid and cells. Glucose is stored as a glycogen in the liver, and this liver glycogen is around 70 grams only. 70 to 75 grams, mainly range is between 25 to 130 grams. So preformed glucose means the glucose present in the extracellular fluid and stored as hepatic glycogen is sufficient only to provide glucose for normal functioning of the human body for up to 3 to 4 hours. And after that, we need further glucose to maintain the normal cellular function. So gluconeogenesis is important for maintenance of plasma glucose concentration when fasting extends beyond 8 hours or beyond 12 hours. So in like in overnight fast, the morning fasting plasma glucose level is maintained within the normal range, mainly by the gluconeogenesis. So this is the very interesting graph which denotes actually 5 phases of glucose homeostasis. Five phases of glucose homeostasis. The first 4 hours after the feed, after the nutrition we take, the first 4 hours glucose is maintained mainly by the exogenous glucose, that is glucose derived by the nutrition. And after 4 hours, between 4 to 16 hours, the glucose level is maintained mainly by the glycogenolysis, that is breakdown of glycogen. And after 16 hours, gluconeogenesis takes the first hand, and the main supply of glucose after 16 hours to 28 hours and beyond 28 hours from 2 to 40 days, gluconeogenesis is the main source of the glucose in the human body. So in the first 4 hours, Origin of blood glucose is exogenous, and tissue using glucose, all the cell types used glucose, and major fuel for the glucose brain is the glucose. In the second phase, from 4 to 16 hours, glycogen is the main source of the glucose, and all cells except muscle and liver and adipose tissue uses glucose. And in the stage 3, hepatic gluconeogenesis is the predominant mechanism, and still in this stage, glucose is the major fuel for the brain. And stage 4 and stage 5, the major fuel for the brain shifts from the glucose to ketone bodies. So if there is prolonged fasting, then ultimately brain starts using ketone bodies as a fuel instead of the glucose. So if fasting prolongs more than 24 hours, gluconeogenesis is the main source, and glucose utilization by the muscle and fat decreases in this time frame, and lipolysis and ketogenesis starts increasing at this stage, and ketone bodies become the major fuel for the brain. So if fasting prolongs more than 40 days, then ketone becomes the main energy source of the brain, and it comprises 80 to 90%, and kidney provides half of the endogenous glucose production by gluconeogenesis if fasting is more than 40 days. Mainly gluconeogenesis takes place in the liver and kidney. Liver is the main source of the gluconeogenesis, main site for the gluconeogenesis, but when fasting is more than 40 days, then kidney also contributes significantly to the gluconeogenesis. So for the gluconeogenesis and glycogenolysis, there are various key regulatory enzymes are present, like glucose 6-phosphatase, which is mainly involved in the glycogenolysis, pyruvate carboxylase, phosphoenol pyruvate carboxykinase, and fructose 1,6-biphosphatase. These 4 enzymes are basically key regulatory enzymes in the process of glycogenolysis and gluconeogenesis, and further we see in detail about this. So the basic glucose metabolism is started from the glycogen. If glycogenolysis, after glycogenolysis, it converts to the glucose 1-phosphate, glucose 6-phosphate, and this and glucose basically enters into the glycolytic cycle. After glycolysis, triose phosphate is formed, and which converts into the phosphoenol pyruvate. This phosphoenol pyruvate actually goes to the TCA cycle or citric acid cycle, and at the end of glycolysis, acetyl-CoA is also formed, which acetyl-CoA is basically the main source for the ketogenesis. So basically there is complex interplay between starting from the glycolysis to the TCA cycle or to the EMP pathway, further by this ketogenesis, and so for all these, the important enzymes which are mentioned in the bracket in the like hexokinase, glucokinase, glycogen synthase, phosphofructokinase, PEP carboxykinase. So again, this is the pictorial representation of the same. I am not going into detail because it is a very complicated things, and it is very difficult to explain in this short duration of the time to the whole TCA cycle and citric acid cycle and this ketosynthesis. So basically, glucose is maintained within the normal range by mainly 4 hormones. The first important hormone is the insulin, which brings down the glucose, and there are hormones which has just opposite actions of the insulin, that is known as the counter-regulatory hormones. And in these counter-regulatory hormones, glucagons, catecholamines, growth hormone, and cortisol, glucocorticoids. So glucagon, growth hormone, and glucocorticoids, these are the 3G indicated in this topic: glucagon, growth hormone, and glucocorticoids. And besides these 3G, one important hormone which plays a very important role in the glucose homeostasis is the catecholamines. So we all know that insulin and glucagon is synthesized from the pancreas. Alpha cells secretes glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. And these 3 hormones actually at the paracrine level interacts with one another, just like insulin inhibits the secretion of the glucagon, Somatostatin inhibits the secretion of both insulin and glucagon promotes the secretion of the insulin. So there is interplay between these the three pancreatic hormones. Somatostatin inhibits both insulin and glucagon. Insulin inhibits the secretion of the glucagon, and glucagon whereas promotes the secretion of the insulin. So these are the very important mechanisms. So if we have to see the interaction between these regulatory hormones and the counter regulatory hormones. The best example is the hypoglycemia. So let us see hypoglycemia. So basically hypoglycemia, since I have already discussed that glucose is the main fuel for the brain. So normal functioning of the brain, glucose should be maintained within the range, and whenever blood glucose starts declining, even in the physiological range, like in physiological range is between 70 to 100. So if below blood glucose starts declining from 100 towards the 70, then the first response is decrease in the insulin secretion from the pancreatic beta cells. And this decrease in insulin secretion basically starts at the blood glucose level of 80 to 85 milligram per deciliter. And this decrease in insulin secretion is known as the first defense against hypoglycemia. So if by decreasing insulin secretion, still blood glucose level is not maintained within the normal range and blood glucose starts falling beyond this, then at the level of 65 to 70 milligram of blood glucose, there is second defense starts acting, and this second defense is increased glucagon secretion from the pancreatic alpha cells, and this glucagon is basically the primary glucose counter regulatory factor, and also this is the second defense against the hypoglycemia. So first defense is decrease in the insulin secretion, second defense is increase in the glucagon secretion. And the third defense mechanism is at the same level 65 to 70 milligram per deciliter, there is secretion of the catecholamine hormones, which basically enhance the process of the gluconeogenesis and glycogenolysis, and this mechanism, increased secretion of the catecholamines, is known as the third defense against the hypoglycemia. And the fourth and less important defense mechanism is the growth hormone and cortisol secretion. This growth hormone and cortisol secretion is basically starts functioning when hypoglycemia is prolonged beyond 4 hours, beyond 4 to 8 hours, then this defense mechanism, growth hormone and cortisol secretion, starts taking. And the main growth hormone and cortisol is basically acting by the increased gluconeogenesis, increases the insulin resistance, and we see further in the in the few slides. So, and even after these mechanisms, defense mechanisms, blood sugar level falls to 50 to 55 milligram per deciliter, then there is again defense mechanism is known as the behavioral defense mechanism. And what is this behavioral defense mechanisms? There is a starting of the symptom of hypoglycemia, like hunger. So there is extreme hunger takes place, and after extreme hunger, patient or the human took the food, and this hypoglycemia can be avoided. So, and when hypoglycemia, blood glucose level falls below 50 milligram per deciliter, then there is decrease in the cognitive function of the brain takes place. So basically, regulatory hormones and counter regulatory hormones we have to see. Then the best example is the hypoglycemia, and it is literally, मतलब जैसे हम लोग बोलते हैं ना कि प्राइम मिनिस्टर की सिक्योरिटी के लिए 3-4 लेयर्स हैं, फर्स्ट लेयर, सेकेंड लेयर, थर्ड लेयर, फोर्थ लेयर. Just like that, since glucose is very important to maintain the normal function of the cells, so there are multiple defense mechanisms, 1 to 4 to behavioral mechanisms. So these are the same in the pictorial representation. Now coming to the one slide about the catecholamines, like epinephrine. Epinephrine basically secreted by the adrenergic stimulation, and this epinephrine acts on the liver, and on the liver it promotes the glycogenolysis and gluconeogenesis. On the pancreatic islet cells, it decreases the secretion of the insulin and increases the secretion of the glucagon. At the muscle level, it decreases the glucose transport into the muscles, and at the fat level it increases the lipolysis, and after lipolysis there is increased flux of the free fatty acid into the circulation, and which promotes the insulin resistance and also serves as the fuel for the ketogenesis. So I have already discussed this. Now coming to the glucagon. Glucagon is basically glucagon agonism. What are the actions of the glucagon? So glucagon, the main is the it increases the hepatic glucose output, and at the level of the amino acid it increases the amino acid catabolism. At the lipid level, the main is the increased hepatic lipid oxidation and decreased hepatic lipid synthesis. Hemodynamic level, it increases the blood pressure, it increases the cardiac inotropic effect and also the chronotropic effect. And at the level of pancreas, it increases the insulin secretion and energy homeostasis. It decreases the food intake and increases the energy expenditure. And other effects of glucagon is decreases in the gastric emptying. And so there are various stimulators and inhibitors of glucagon secretion. I am not going into the detail. Stimulators are mentioned on the upper box and the inhibitors are in the lower box. So now coming to the what are the causes of hyperglucagonemia. The hyperglucagonemia, the important cause is the glucagonoma, the pancreatic tumors which produce glucagon in excess, and the other important causes are like renal failure, cirrhosis, hypercortisolism, familial hyperglucagonemia, and the diabetic ketoacidosis is one of the important cause of hyperglucagonemia. But in spite of in addition to these causes of increased glucagon secretion, the most common cause of increased glucagon secretion is the type 2 diabetes. So in type 2 diabetes, as we all know that in the concept of forminous octet given by DeFronzo, one of the main important pathogenetic mechanism is the increased glucagon secretion from the pancreatic alpha cells. So the commonest cause of hyperglucagonemia is the type 2 diabetes. Besides type 2 diabetes, other are the less common causes like glucagonoma, chronic renal failure, chronic liver disease, etc. And to target this, the one of the drug is the DPP-4 inhibitor. Basically DPP-4 inhibitor what causes? It causes the decrease in the glucagon secretion, is one of the important mechanism for the action of the DPP-4 inhibitors. And what are the other mechanisms are the increased glucose dependent insulin secretion from the pancreas, and also it delays the gastric emptying. But one of the important important mechanism of action is decreased glucagon secretion from the alpha cells. So another drug is just I just want to highlight here is the effect of SGLT2 inhibitor on the glucagon. SGLT2 inhibitor is basically it acts in the, we all know that it inhibits the glucose reabsorption from the kidney. Besides that, there are other mechanism of action of SGLT2 inhibitors, like it increases the insulin sensitivity in the muscle by increases GLUT4 translocation and insulin signaling. It also increases the insulin sensitivity in the liver by decreasing glucose 6-phosphatase enzyme. It promotes, it decreases the gluconeogenesis, and besides this, it also increases the glucagon secretion. So that is one of the important thing we have to know, that SGLT2 inhibitor can increase the glucagon secretion. So if we combine both DPP-4 and SGLT2 inhibitor, DPP-4 inhibitor causes decrease in the glucagon secretion, SGLT2 inhibitor causes increase in the glucagon secretion. So this glucagon effect is actually nullified, and we get the more benefits with the combination of DPP-4 and SGLT2 inhibitors. So the manifestations of hyperglucagonemia, the 3D is the symptoms like diarrhea, dermatitis, and diabetes. Besides these 3D, weight loss, abdominal pain, and anemia are the other symptoms. Diagnosis of glucagonoma is measured when plasma glucagon level is more than 1000 picogram per ml. Normal is less than 150. And these glucagonoma are actually slow growing tumors. So at the time of diagnosis, they are usually large, 5 to 10 centimeter, and most of the glucagenomas are present in the pancreatic tail region. And almost 50 to 80% of the patients of glucagonoma had hepatic metastasis at the time of diagnosis. And the treatment of glucagonoma, curative surgical resection is not possible because in most of the cases there is hepatic metastasis. So the main treatment is the surgical debulking of the tumor, and octreotide and lanreotide somatostatin and long-acting somatostatin analogs like octreotide and lanreotide can be used. That can cause improvement in the skin rash, diarrhea, weight loss, but they do not improve the glucose intolerance present in the glucagonoma. So now coming to the growth hormone. Growth hormone is the most abundant anterior pituitary hormone. There are various stimulatory factors and inhibitory factors for the growth hormone secretion, but the most important are the growth hormone releasing hormone from the hypothalamus, which stimulates the GH secretion, and somatomedin, which inhibits the growth hormone secretion. Growth hormone has mainly there are various actions of growth hormone. The growth promoting action is actually mediated indirectly via the action of the IGF-1. Growth hormone acts on the liver, and by acting on the liver, it produces the IGF-1, insulin like growth factor 1, and this IGF-1 acts on the bone level and to promotes the growth. But there are various actions of growth hormone which are independent of the IGF-1, and these are known as the metabolic actions of growth hormone, and these metabolic actions are mainly mediated by the growth hormone, but there are also some contribution of IGF-1 also. So main action of metabolic actions are: it promotes the fat metabolism, it increases the clearance of LDL at the liver level by increasing the expression of the LDL receptor, and that's why in case of growth hormone deficiency, there is increase in the LDL level is present, and that promotes the atherogenesis. So it also promotes the protein synthesis, decreases the urea synthesis. It also promotes the sodium, potassium and water retention, and increases the serum level of the inorganic phosphates. So growth hormone basically it stimulates the lipolysis via the activation of the hormone sensitive lipase. So if by lipolysis there is increased free fatty acid to the flux to the into the circulation and into the liver, and this increased free fatty acid flux causes insulin resistance. And the other mechanism, it also increased free fatty acid flux causes decrease in the activation of the PI3 kinase, which is a very important mechanism for the action of the insulin. So increase in free fatty acid uptake by the hepatocytes also promotes the lipid oxidation, and by lipid beta oxidation of the lipids, acetyl-CoA is produced, and this acetyl-CoA basically stimulates the two key enzymes for the gluconeogenesis, which is pyruvate carboxylase and phosphoenol pyruvate carboxykinase. And besides these two gluconeogenic hormone, it also stimulates the synthesis of the glucose 6-phosphatase enzyme, which is the main regulatory enzyme for the glycogenolysis. So by these mechanisms, growth hormone promotes glycogenolysis and also promotes the gluconeogenesis. So effect of growth hormone on glucose metabolism, I have already discussed. So growth hormone excess condition is acromegaly. We all know the we have already discussed the effect of growth hormone. Acromegaly, how will you diagnose? A screening test for acromegaly is the age and sex matched level of serum IGF-1 level. Measurement of random growth hormone has no value, and confirmatory test for the diagnosis of acromegaly is growth hormone suppression test following after giving 75 gram of oral glucose, and failure to suppress GH level below 0.4 microgram per liter is the confirmatory test for the diagnosis of acromegaly. These are the only, and the treatment is the surgical resection of the tumor, pituitary tumor. Besides surgery, long-acting somatostatin analog like octreotide and lanreotide can be used for the pre-operative period also for the shrinkage of the tumor, and where the patient denies surgery, in that case long-acting somatostatin can be used. The other options are the pegvisomant, which is the GH receptor antagonist, and the drugs like bromocriptine and cabergoline, which are the dopamine agonists, can be also used in the treatment of acromegaly, mainly in the GH and prolactin co-secreting tumors. Now coming to the glucocorticoids. These are the various effects of glucocorticoids. Now, since time is less, I am skipping all these slides. So, at the pathophysiology level, glucocorticoids At the pancreatic beta cells, it causes decrease in the insulin secretion, and at the liver level, it causes increase in the gluconeogenesis. At the skeletal muscle level, it decreases the glucose uptake by the muscle and adipose tissue also. It decreases the glycogen synthesis and it increases the proteolysis, and at the adipose tissue level it causes lipolysis and decreased glucose uptake into the adipocytes. So these are the main physiologic actions of the glucocorticoids. So Cushing syndrome is one of the causes of growth hormone excess, cortisol excess. It can be endogenous or it can be exogenous. Exogenous glucocorticoid excess is the most common scenario. Cushing syndrome is relatively less common. So glucocorticoid induced hyperglycemia at the level of liver, it promotes gluconeogenesis. Pancreas decreases insulin synthesis and increases beta cell destruction. At the muscle level, decreases glycogen synthesis, decreases glucose uptake and promotes proteolysis. And at the fat level, it causes lipolysis and decreases glucose utilization at the level of the fat. So risk factors for the exogenous, when exogenous glucocorticoid is used, what are the risk factors for the hyperglycemia? So it basically depends on the type of the steroid, duration of the steroid and dose of the steroid. So there are various doses already mentioned. So one important mechanism where this regulatory and counter-regulatory hormone is important is the diabetic ketoacidosis. So normally in a normal human being, when plasma glucose gradually decreases, there is decrease in the insulin secretion and increase in the glucagon secretion. This mechanism causes increased free fatty acid in the liver, and this free fatty acid is utilized for the ketone synthesis. And this ketone synthesis, basically when ketone is formed, it decreases the lipolysis and it causes increase in the secretion of the insulin from the pancreatic beta cells, and this increase in the insulin secretion from the pancreatic beta cells stop the ketone synthesis. This is the normal physiology. But what happens in type 1 diabetes, that when ketone, there is formation of the ketone body, there is increase in insulin release and prevents further lipolysis does not take place, since there is no insulin synthesis takes place in the type 1 diabetes. So that leads to the further ketone body synthesis, and that leads to the main important factor for the diabetic ketoacidosis. So in diabetic ketoacidosis, basically, just I will take 2 minutes more. Not only there is relative or absolute deficiency of the insulin is important, but also there must be increase in the glucagon secretion and increase in catecholamine secretion is must. And this insulin glucagon ratio or glucagon insulin ratio, disturbance in this ratio is must for the ketogenesis and diabetic ketoacidosis to take place. And that's why in diabetic ketoacidosis is more common in type 1 diabetes, and in case of pancreatic diabetes, since there is no glucagon excess, so in case of pancreatic diabetes, diabetes is usually of milder type, and usually there is no risk for the development of the diabetic ketoacidosis. With this, I will end my talk here. Thank you.
Thank you, Ved Prakashji. You have covered all the total type 1, type 2 and the others diabetes mellitus. Just to sum up, there is a question to the PG aspirants. What is the dysglycemia? What is the hyperglycemia? What is the hypoglycemia? Whether the dysglycemia includes all the hyperglycemia, the IGT, the impaired fasting glucose, and the hypoglycemia, whether or not. In the recent text, dysglycemia is implicated in the type 1 diabetes mellitus in a stage 1, a stage 2, in the gestational diabetes mellitus. That indicate the dysglycemia defines the impaired glucose tolerance. Number 1. Number 2, if you see the relation of the glucagon, growth hormone, and the corticosteroid in the relation of the diabetes. Whether they increase the number of the diabetics or not, definitely. Definitely, corticosteroid we are using more than 1% population, and the growth hormone we are using for the different growth increase. So, in acromegaly, at least 70% of the patient come with the impaired glucose tolerance or the diabetes. Excess glucagon, and the one more thing last, whether the glucagon can be used in the type 2 diabetes mellitus or not. If anyone can explain this in the lunch time. Okay, thank you.
Sir have some comments.
So two questions are allowed, so one of them, and I think this is the last one. We learned a lot, Ved, from your talk. The glucose homeostasis, it was just a recapitulation. The very thought of this 3G was just to remind us all about the implications of these hormones. And I had requested Ved to cover all the defense mechanism and the hyperactivity, what happens. And because of the time frame, he just omitted what we were discussing in the quiz section about the triagonists which we are using now, the agents which can stimulate both glucagon, GIP, and glucagon. The benefit of glucagon primarily is at the level of the liver. We have less of a steatosis when we are having that. The VLDL secretion and the atherogenicity is taken care of by the glucagon activity, and glucagon is said to be the holy grail of energy expenditure. So one of the mechanisms of weight loss from SGLT2 inhibitors is putatively SGLT2 inhibitors. Regarding Dr. Surendra's question, whenever we give glucagon, definitely there are chances of stimulation of insulin. So it's a very safe agent for managing hypoglycemia in type 1 diabetics. In type 2 diabetics, the problem is there can be rebound hypoglycemia because of the increased stimulation of insulin secretion with glucagon. So at the onset, you can manage hypoglycemia, but there are chances of having rebound hypoglycemia consequent upon the insulin release. And this is a technical problem when you are using the hybrid pump. We can give insulin, we can give glucagon, but the time frame of action of this glucagon doesn't match with the glucose profile. So this becomes a disadvantage even in that scenario. And a very recent paper, this was after Ved's topic was allotted, the importance of these three hormones, glucagon, cortisol, and growth hormone, in the pathogenesis of having type 2 diabetes. And this was studied in pre-diabetics. Very interesting one. Mechanistics always appeals to me. And in that, the glucagon increase is definitely there, and it is linked with a reduction of insulin sensitivity at the level of the alpha cells, the sensitivity of glucose for the alpha cells, and the last part is the hepatic glucose resistance. So these are all impacted by in the pre-diabetic state with glucagon. Cortisol is same. You have a hyperreactivity of CRH in patients with pre-diabetes, particularly due to stress. And there is resistance to glucocorticoid suppression of ACTH. So these are the two mechanisms where it has been correlated with the dysglycemia and the importance of growth hormone. It is a bit paradoxical. Growth hormone deficiency has been linked with insulin resistance, and growth hormone treatment has been found to favor the glycemic control. And there are injections of IGF-1 which are available even in the management of type 1 diabetes where we are having problems with the management. So growth hormone is just reverse in type 2 compared to type 1. And simple example will be Dawn phenomena. In that you have increased growth hormone, there is increased elaboration of Dawn phenomena, which is not seen typically in type 2 diabetics, and this is because of the suppression of growth hormone, and that is consequent upon insulin, that is consequent upon increased IGF-1 and the increased free fatty acids, and more so about somatostatin, which suppresses growth hormone, and that is linked with the obesity. So increase obesity, increase somatostatin, suppression of growth hormone. So these are very important kinetics. Thank you once again, Ved, and my sincere thanks to the chairpersons for this interesting session. Thank you.
Thank you, sir, for your excellent comment on this. So I just would like to honor the speaker. So, so so and I would like to ask Dr. Prakash and Dr. Sajjad to come over and honor our chairpersons, Dr. Vijayachari sir and Dr. Surendra Kumar sir. एक एक आदमी दे दीजिए. So before moving to the next session, may I call upon Dr. Devendu Bhushan to just give the prize money to one Thai team, which we actually forgot to give. So I ask our secretary and Devendu Bhushan sir to call those team and get their prize money. So I'll be then moving to the next session.
We missed the one team. It is Dr. Varsha and Dr. Priyanka from PMCH. They are also stood third in the quiz. Please have a round of applause. Dr. Varsha and Dr. Priyanka, please come over.
So the hot beverage is also ready behind. So anyone who is interested, they can go and get the tea or coffee and come back. So coming to the next session, we have next session which will be delivered by Dr. Syam Kishore, and to chair the person, may I call upon Dr. N.P. Verma sir and Dr. Kaushal Kumar sir.
diabetes is a multi-system disease. Right at the time of diagnosis, we need to see certain complications. At the same time, the management also depends upon the targeting the complications. We have with us Dr. Shyam Kishore, who will be discussing the management aspect, particularly focusing on the cardio-metabolic and renal parameters. So over to Dr. Shyam Kishore.
Good morning to you all, and thank you, chairpersons. I would like to highlight the cardio, renal and metabolic aspect and how you can manage these cardio, metabolic, renal aspect by the different drugs available for the management of diabetes. So, what is the demand of time? An opportunity lies in intervening well advanced in time, address the key pathophysiological change happening over the period due to prolonged dysglycemia. Suvendra sir was rightly mentioning the dysglycemia. So, the rise in the blood glucose level is not a one-day phenomena. Once the blood glucose level rises, the things starts happening quite before that, and the complications of diabetes, you can say, starts long before that. So you need to address these things well before the time. So these are the facts and figures I have taken from the IDF Atlas. These are not only the numbers. These numbers are the showing how significant these numbers are and what we are going to deal. We all know the complications of diabetes and what could be the impact of these numbers if you translate it into the number, into the complications, even in the different percentage. So, as per the Government of India data, August 23, the number of diabetic patients is 10.1 crore in India. Out of that, more or less 50% remain undiagnosed. And if you take the number for the CKD patients, as per the 2017 data, 1/3 of the CKD patients lies into the India and China, and out of that 115 million patients are in the India. And similarly for the heart failure, you will see the more than 10 million patients of heart failure. So you are not only going to treat the patients of diabetes, you have to look into the fact of the CKD, you have to look into the fact of heart failure as well. So these, we have recently, there is a talk about the upstream pathway management of dysglycemia, and this is talked more into the terms of the GLP-1 agonist like semaglutide for the weight management in the patients. I would like to apply that frame here. So you have not only to treat the diabetes, you have to keep in your mind that my patient could have the heart failure, my patient could have renal failure. They might not have presented biochemically, but the things should have started earlier. So your medication should be in the targeted, keeping this fact in your mind. So the epidemiology of diabetic nephropathy, if you will see the different, if you will see the different epidemiological data from the diabetic nephropathy, it would be from 0.9% to 62.9%. So see the gravity of the diabetic nephropathy complication. So epidemiology of diabetic nephropathy in India, the prevalence of diabetic nephropathy ranges from 0.9 to 62.3%. As I had mentioned, the magnitude of problem is expected to increase by 170% in developing countries. Type 2 diabetes mellitus emerged as a second leading cause of CKD and CKD-related death, and the prevalence of overt nephropathy and microalbuminuria is 26.9 and 2.2% respectively. This is the Chennai-based urban-rural epidemiological study. And in a 12-year observational study in India, Viswanathan et al. Reported that 44.1% people of type 2 diabetes develop proteinuria in follow-up. So these numbers are only indicating that how much significant these complications are and we should target these complications well advanced in time. So, this was not the part of the talk, but simply I would like to mention by one slide the another metabolic complication is non-alcoholic fatty liver disease. Indian study has shown that it's more common in female than in male, and type 2 diabetes patients with prevalence of NAFLD vary from 44.1% in Western India to 72.4% in Northern India. So now in patients of type 2 diabetes, you are looking for the NAFLD, and you have to keep this fact in mind that NAFLD can progress to the cirrhosis of liver and finally liver failure, and that requires the liver transplantation. So this is one of the metabolic complications of the metabolic complication. You must look into the cases of diabetes. So cardiorenal and metabolic systems are well interconnected. The energy requirement of the heart is dependent upon fatty oxidation and glycolysis, and they are particularly in the patients of diabetes and obesity, the reliance on the fatty acid oxidation goes down, and so any imbalance between these energy homeostasis system can lead to the heart failure. And we all know that the kidney is one of the sites where either the glucose is going to be absorbed, or it has to be it will be absorbed, or it will be excreted when the drugs will be used. So kidney's role in the glucose metabolism is also important, and liver, pancreas, and adipose tissue and muscles are simultaneously involved in the glucose homeostasis by the different neuropeptides and the hormones. So let us have a hypothetical patient case vignette that 38-year-old type 2 diabetes patients uncontrolled on metformin. His duration of diabetes is 2 years. Current medication is only metformin, 1 gram twice daily. HbA1c is not at target, and it is 8.1%, and BMI is 29.7 kg. History of hypertension, for that he is taking telmisartan 40 milligram per day. He is a smoker, and his eGFR is more than 90. And there is no albuminuria. So what are the things we have to look into these patients? So we have to reduce the HbA1c of this patient. We have to reduce the body weight of this patient. We have to reduce the blood pressure of this patient. We have to reduce the CV event of the patient and CV risk of this patient. Increase the quality of life of this patient, and increase the life expectancy. Can we have either a single drug or a combination of drug which can do all these things? Definitely, that we will discuss in next slide. And this is the one of the ICMR India 17 study. More than 1 lakh population patients had been studied, and we can see what percentage of Indian population having different risk factors. And these risk factors are if you talk about the number of diabetics, the fairly good number of patients are pre-diabetics, dysglycemia, hypertension, metabolic obesity, hypercholesterolemia, and increased LDL levels. So these numbers has to be taken care of. So this was a South India based near about 4 states. This had near about 700 patients had been studied, and they had looked for the metabolic and anthropometric parameters of the patients. And these patients were clinically or screen detected diabetes patients. You can see those patients who had been seen in the clinics having HbA1c of the more than 9.1%, and those who had been screen detected diabetes, their HbA1c was 8.3%. And what does this study signify? That if you will see the patients presenting into clinic, they are presenting late, and if you are arranging them any screening detected diabetes program, they are screened at earlier level. So this shows the significance of the community level screening of the diabetes. So, and this same ICMR India study, if you will see that the patients of diabetes, here you can see the HbA1c, less than 7% of HbA1c is seen in near about 30 to 36% of patients. So another cardiovascular risk factors, micro and microvascular complication diagnosis in patient with young onset. This less than 40 years of the diabetic patients, and it had been seen that the age of presentation is not between 20 to 40, their age of presentation even less than 20%. The mean age of diagnosis was near about 34.6 years. The HbA1c was 9.86 and BMI is 26 point. The BMI cutoff of Indian is 23 kg per meter square. And with the increasing age, the HbA1c level was all not that increasing. It was the more in the age group of 21 to 30. And the significant highlight of this study was the 95% of patients required a statin in this study, and this was not only in the age group of 21 to 30, 30 to 40, but even in the less than 20, and if you will accumulate the data, the near about 95% required the statin therapy. So cardiovascular risk categorization in type 2 diabetes, it can be categorized in very high risk, severe risk patients, those who have established atherosclerotic cardiovascular disease, or those who have target organ damage. Target organ damage is defined as the EGFR less than 45 with or without microalbuminuria or microalbuminuria, or all the three microvascular complications, or EGFR of less than 60 with either nephropathy, neuropathy. So high risk patients, the patient with type 2 diabetes not fulfilling the very high risk criteria, 10-year CV risk is between 10 to 20%. And why you need to categorize your patients into this category? Because you will require medication to save these patients. As I was telling earlier, by the time of diagnosis, we start to develop the microvascular complication, but the microvascular complication development of atherosclerotic disease starts well before the diagnosis of type 2 diabetes. And usually these risk factors, there are the risk factors like dysglycemia, like dyslipidemia, hypertension, smoking, these will accelerate the progression of the risk. So this metabolic consideration in context of the cardiometabolic risk factor, this is from the UK PDS study. It had been seen that those patients who had been put into the tight glycemic control arm, there was a 25% reduction in microvascular complication, particularly of diabetic retinopathy, and only 16% non-significant reduction in the myocardial infarction. The 10-year follow-up is these patients had shown that almost 24% reduction in the microvascular complications and only 15% reduction in the macrovascular complication. And these macrovascular complications, particularly of the myocardial infarctions, was more in the patients of those patients who had been receiving the metformin group. So now coming to the management of the hyperglycemia in type 2 diabetes as per the ADA and EASD guideline, you start with the lifestyle modification, then you go for the metformin, then the things start from here. What we should do right now, either you have to add on, or your patient is not well controlled on any other medication, on the metformin and lifestyle medication, which drug we should opt. Now we have drugs with evidence of their cardiorenal safety and their effect in the protecting both in the heart and the kidney. So we have to select medications from those drugs which can protect our heart and protect our kidney. So in younger age group with diabetes, consider early combination therapy. Why you are considering, suppose that you have putting your patients on lifestyle modification, then putting on the metformin, then you are taking long time and your patient is going to expose for the longer period of time and he is going to have more number of complications. So start early optimum combination therapy to prevent the early onset of the complications. So what would be the best combination which can offer us for the treatment of type 2 diabetes mellitus? And SGLT2 inhibitors and DPP4 inhibitors, so they complement each other. Some of part of this discussion was highlighted by the Ved, that this acts on the different part of the body, gut, liver, pancreas. Not only the beta cells of the pancreas, they act on the alpha cells of the pancreas, muscles, kidney, and the SGLT2 primarily acting on the kidney, whereas the incretin hormones are acting primarily at the gut levels, and they have the complementary action, and by the complementary action they can provide a better glycemic control. So is there any study which shows that the SGLT2 inhibitors and DPP4 inhibitors had a better glycemic control? So this was the study done in more than 700 patients. In this study, they have used the empagliflozin 25 and linagliptin 5 milligram, empagliflozin 10 and linagliptin 5, and they had compared it with the 25 empa, 10 empa and 5 lina. And you can see the HbA1c control was best with the empa-lina combination at the level of 25 and 10 both. But simultaneously you will see that those patients having higher HbA1c had better glycemic control with this combination. So we have a evidence for starting a combination therapy. So once your patient either not well controlled on the lifestyle and metformin, or metformin is contraindicated, you plan to start any combination therapy, you can opt for this combination of the empalina. So the extrapolation of the data from the same, the early achievement of good and durable control, you can see the earliest control they started both in the 10 and 25 plus Lina 5. You have started to see it at 6 weeks and well established at the 12 week, and which sustained up to 54 weeks. And these patients had achieved the HbA1c of less than almost 6.9 or less than 7. So if you will see that both the combination, you can see the combination have achieved more than 2 times in comparison with the drug alone, either EMPA or 10 EMPA 25 of Lina. So HbA1c less than 7 was achieved in more than 2 times patient than in. So what are the other benefits that can be provided to our patients? The potential pleiotropic benefit is the weight reduction near about 3 kg. 3 kg in the EMPA 25 and Lina 5, in the 10 or 5 it is near about 2.6 kg, and simultaneously the BP reduction could be also there in the both EMPA 10 and EMPA 25 plus linagliptin patients. So this was the International Journal of Clinical Practice, empagliflozin single tablet combination first optional therapy. The empagliflozin, the sitagliptin single tablet can reduce the HbA1c of approximately 1.1%, mean body weight of 2 to 3 kg, and it can simultaneously reduce the systolic blood pressure. And another advantage that these drugs are either it can cause weight loss or weight neutral without or almost minimal risk of hypoglycemia. So this is, I would like to highlight this study. This was a meta-analysis published in Diabetes, Obesity and Metabolism. The 16 trials representing the total near about 47,000 patients were included. SGLT2 inhibitors significantly reduced the kidney-specific composite outcome by 26% when compared with the GLP-1 receptor agonist, and 36% compared with the DPP4 inhibitors. The risk of MASH was significantly reduced with the SGLT2 inhibitors, almost 18%, and with the GLP-1 receptor, both the MASH reduction was same in the GLP-1 and SGLT2 inhibitors. The SGLT2 inhibitors significantly reduce the risk of heart failure, 28% when compared with the GLP-1 receptor agonist, and 41% compared with the DPP-4 inhibitors. So there is a clear advantage of adding SGLT2 inhibitors in reducing the CV events and the renal events. So even the ADA standard medical care guidelines suggest that if your patient is having atherosclerotic cardiovascular disease, heart failure and CKD, you can opt these medications as per your choice, and if there is not, they are contraindicated due to any reason, you can opt either any one of these two. The cardiorenal metabolic risk reduction, all these study, EMPAWAY, CANVAS program, Declare TIMI, CANVAS, they all had established these drugs have the CV benefits. The EMPAWAY, CANVAS and Declare TIMI, they early and sustained HbA1c reduction was seen in the 38% relative risk reduction was seen with the empagliflozin. This Caromelina trial was a non-inferiority trial, other than the SAVOR-TIMI trial, in which there was increased incidence of heart failure with the saxagliptin, and the TICOS with the sitagliptin, both were non-inferior for the cardiac safety point of view. So what may be the possible benefit to this patient we can offer? So what should be the aim of selecting the medication before, at the time of presentation, or in it already getting treatment or triptan naive patients? A specific medication choice should be tailored to the need of the individual patient. You have to see the initial HbA1c, duration of diabetes, the comorbid conditions, cardiac, vascular, renal status and risk of hypoglycemia, whether this drug is going to cause hypoglycemia or not, the available social support and the patient preference, and whether the patient is a treatment naive or is requiring add-on therapy. So in your patient, there was a need to reduce the blood sugar level, but there was a need to reduce the blood pressure and the lipid. So this combination of SGLT2 inhibitors, empagliflozin and DPP4 inhibitors, dapagliflozin would be the best answer in these patients. Thank you.
Good morning. Thank you, Dr. Shyam Kishore, for your excellent words. The topic itself is very interesting because the title is Optimizing Cardiorenal Metabolic Care with Initial Combination with SGLT2 Inhibitor and DPP4 Inhibitor. We all know that nobody dies of diabetes per se, but they die because of complications of diabetes. And till date, my knowledge says that there are only two classes of drugs. One is SGLT2 inhibitors and the other is some of the GLP-1 receptor analogs, which are going to give you cardiorenal benefits. So it was interesting to see whether adding linagliptin or any gliptin to the SGLT2 inhibitor is providing any additional cardiorenal benefit or not. Probably they are complementing the action of the SGLT2 inhibitor, and they are reducing the chances of genitourinary tract infection. I don't think they are providing any extra cardiorenal benefit to the SGLT2 inhibitors. That is my understanding, and I think the more work will throw more light on this combination so far as the benefit of cardiorenal is concerned, and the questions are now invited.
I fully agree with the chairperson, and that SGLT2 inhibitors and certain GLP-1 receptor agonists do provide cardiorenal protection. I'd like to add that in certain groups, as shown way back in the UKPDS, particularly obese diabetics, metformin also has cardiovascular protection. As far as DPP-4 inhibitors are concerned, they are cardiovascular neutral and renal neutral. That means they do a moderate reduction in the blood glucose level. But as far as they do not produce or they do not cardiovascular harm, they are not harmful to the cardiovascular system in any way or to the kidneys. But protecting these organs, you will have to have an as you rightly showed in the chart. And all the guidelines, whether it is ADA or EASD, you will have to have a GLP-1 receptor agonist or SGLT2 inhibitor, in addition to metformin.
The entire landscape of the management of diabetes since 1960 to 2023 has changed. In 1960, when university group diabetes program, when tolbutamide was discussed, it was supposed that it is going to provide the harm. Now we have reached into the era of drugs where we have evidence that can protect our heart and kidney. Definitely, linagliptin is not going to add what it is going to add, because it is a renal safe and you need oral drug which can reduce the blood glucose level. That's why it is added. It is cardiac neutral. So among the DPP-4 inhibitors, this drug which can be given into the patients of diabetic kidney disease, even CKD patients, it can be given. And SGLT, and remarkably, it has a best evidence for the SGLT2 inhibitors. Even in the now there are some thought going on even before those who have not required dialysis and those who are not going for the renal transplant. Up to that extent, they can tolerate empagliflozin. Studies are in favor of empagliflozin. You can give it this in combination.
I would like to add another point that is now accepted both by the European Society of Cardiology and also ACC-AHA guidelines 2021-2022, that there are 4 principles of treatment of heart failure. One is ARNI, which is quite expensive, sacubitril, valsartan, or you can, in Indian context, you can use an ACE inhibitor or ARB, SGLT2 inhibitor, and mineralocorticoid receptor agonist, and antagonist, and a beta blocker. And this is regardless of whether the patient is diabetic or non-diabetic. It applies to.
Thank you, sir. Thank you. Thank you. So, to honor our speaker, may I call upon the chairpersons and give the memento to the speaker. And to honor our chairperson, may I call upon Secretary of BDF, Dr. E. Haq, sir, to honor our chairpersons.
It is an honor to receive a memento from सबसे जुझारू व्यक्ति इस पूरे पटना में एसोसिएशन चलाने के लिए.
Thank you, sir. Thank you. So coming to the next session, this next session is very interesting session that will be delivered by none other than Dr. Santosh Kumar Singh, sir. And to chair the session, may I call upon Dr. Usha Didwania, ma'am, and Dr. H.K. Singh, sir.
काम कर रहा है ना?
Good morning to everybody. Dr. Santosh Kumar Singh needs no introduction. He is known to everybody and he is all-rounder. Although the absence of Abharani Sinha, immediately he fulfilled the subject. So he is going to deliberate the diabetes in pregnancy.
Honorable chairpersons, respected seniors and friends, my apologies at the beginning for my inadequacies, if there be any. So diabetes in pregnancy, and this is well known to us. We were having a quiz and the prevalence you can see 1 to 20%, and it depends on the background type 2 diabetes population. When we talk of diabetes in pregnancy, we need to understand these two entities, and what we correlate with gestational diabetes is glucose intolerance with onset or first recognition during pregnancy. So this is important to know. And the other is if you have pre-existing diabetes, and that can be any. If you remember the classification ADA, it is type 1, type 2, other specific types, all can fall in that category of pre-existing complicating pregnancy. Now, effects of pregnancy on blood glucose, this is known to us. Nutritional demands by the fetus, metabolic changes in the mother, and it transforms in this scenario. So insulin resistance, increased fat catabolism, reduced muscle mass, and it is a state of accelerated starvation. Increased insulin resistance, and this stems from the hormones which we didn't talk in the morning, and these are the human placentral androgen, prolactin, progesterone, and cortisol during pregnancy, which can aggravate the insulin resistance, and this leads to hyperinsulinemia. But interestingly, despite this hyperglycemic milieu, we have this entity of euglycemic decay, which is typical of pregnancy. We have a lower blood glucose, and this is because of the increased glucose clearance from the kidneys, increased fasting insulin, which is consequent upon this hyperinsulinemia, and decreased hepatic output. And this is because of, if you remember Beth's slide on the importance of the neogluconidic substrates, including alanine. This passes towards the fetus, less so for the maternal hepatic glucose production. And lastly, there is dilution of the glycemia because of the increased blood volume. So these are very interesting aspects of having a lower blood glucose in pregnancy. This is again an interesting one: integrated metabolism, anabolism, insulin resistance, hyperinsulinemia, and that can lead to hyperglycemia. You remember that slide on accelerated starvation, and that is linked with lipolysis, ketogenesis, and hypoglycemia. And this is important because we look for ketones in both for knowing the hyperglycemic milieu because of insulin deficiency, and also to know the ketone formation in a state of accelerated starvation because of lower intake of food. So both these things can lead to ketosis during pregnancy. Now that was effect of pregnancy status in diabetes, and this is just the reverse. Diabetes on pregnancy. This is a very important slide. Glucose, amino acids, ketones, they directly pass towards the fetus. Triglyceride is broken down and then it enters the fetal circulation. Insulin, glucagon, peptides, they cannot pass, and hence it is very much understandable. But whatever problems we have in the fetus, it is consequent upon the nutrient delivery from the mother to the fetus. And this is the facilitated diffusion. As you can see, insulin deficiency, increased plasma glucose, amino acids, and this passing towards the fetus, there will be increased insulin secretion from those nutrients, which stimulates growth and is responsible for macrosomia. So as you can see, and this is known to all of us, the Pedersen-Finkel hypothesis, Maternal insulin deficiency leads to increased catabolism, increased nutrient flux, what you can see in the picture, and leading to macrosomia. Now, effects of fetal hyperinsulinemia. So if you have the increased insulin in the fetus, this can produce all this, and this is known to us. Even at the MD level, we were knowing these things. Increased growth of insulin-sensitive tissues, increased deposition of adipose tissue, and skeletal maturation is accelerated, and there is delayed pulmonary maturation, and that again signifies the use of surfactant and glucocorticoids even in diabetic pregnancies, and delay in switch from fetal to adult hemoglobin. This is again an interesting aspect. We do have conditions, almost 7%, where we have persistence of fetal hemoglobin even in the adult population, and polycythemia consequent upon the hypoxia. Potentially teratogenic processes in diabetes pregnancy, and this is very easy to remember. If you remember the frank effect of glycemia and the complications, and the pathways you easily remember, myo-inositol, you have redox potential, DAG-PKC pathway, and the last is advanced glycation end product. So this is what we imagine in our mind when we are talking of the effect of glycemia as such, and the complications micro or macro, and definitely the abnormalities of zinc metabolism. Now, impact of maternal diabetes on fetal development, and these are the complications, and these are the things which were adjusted in the HEPO trial. So we need to know, these are the complications which we can have: excessive growth, macrosomia, neonatal hypoglycemia, C-peptide, and then we have the increased cesarean section delivery because of the macrosomia as such, and definitely increased incidence of stillbirth. So this is the effect of maternal hyperglycemia. Excessive growth, we have, it can be linked with the infantile hyperinsulinemia, it can be genetic. So we need to understand that the baseline, as I said, the GDM is linked with the baseline type 2 diabetes, and here it is important to know even simple increased BMI can be responsible for increased macrosomia. So it is very important. Macrosomia is not inherent only to diabetes. We can have this problem even because of increased obesity. These are the things, and this is for the quiz. The time frame when we have these congenital problems, and this is just to know, this is there in patients who are already having type 1 or type 2 diabetes. They can only be there. In the first trimester, problems will be there. Typical gestational diabetes, glucose intolerance at onset or diagnosis during pregnancy won't have these problems. These are inherent to pre-existing diabetes. And the typical is caudal regression syndrome. This is the most specific one, but most common is spina bifida. So these are the two, and then you have the cardiac and neural problems over there. And to obviate this, it is very important to go for a folic acid supplementation in planned pregnancy in diabetics to reduce these neural tube defects. Effects of diabetes on the neonate we have discussed in that slide: hypoglycemia, hyperbilirubinemia, polycythemia, Hallin membrane disease, surfactant. Long-term impact on the offspring: obesity, hyperinsulinemia, hyperglycemia, and interestingly, it can both be type 2 or type 1. Okay, that is very interesting aspect. We can have both type 2 and type 1. Complications of diabetes: among diabetes complicating pregnancy, we have PET, acidosis, leading to coma, vascular complications, and definitely the infections, urinary and vaginal, which is there even in the background population. Other effects of diabetes on pregnant women, and this is there: polyhydramnios, preeclampsia, preterm labor, postpartum bleeding, spontaneous abortion, increase in cesarean section, and this is just to highlight, everybody is aware of this. Now, this is important when you are asking somebody to plan for gestation. Okay, maternal diabetes complications, this is pre-existing again. Diabetes complicating pregnancy, retinopathy can transiently worsen during pregnancy. Kidney function can deteriorate, and hence it was recommended that you go for a 3-month ACE or ARB treatment in patients who are having albuminuria. Otherwise, during pregnancy, the only thing is that you have to give an optimum amount of even calcium channel blockers and those agents which will take care of the blood pressure and the albuminuria part. You cannot use ACE or ARBs during pregnancy. So if somebody is planning for that, you go for a treatment beforehand and then go for a planned pregnancy. Macrovascular complications, although are uncommon in this age group, but they can be aggravated. We will see in our subsequent slide. An increased risk of death in patients with diabetic cardiomyopathy. So this is very important again. And autonomic neuropathy can lead to anesthetic complications during operative delivery. So just to highlight this aspect. If the patient is harboring micro or macrovascular complications, definitely there are high-risk pregnancies, and we have to be more vigilant in that pregnancy. Now coming to the typical gestational diabetes, and I would reiterate again, this is carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. Prevalence we talked about, 1 to 15% depending on the background population. And last line is very important. In a multi-center study in India, the lowest prevalence of GDM was found in Kashmir and the highest in Tamil Nadu. This was 2004 data. Again, showing the background patient population. Women with GDM are unable to increase their insulin levels sufficiently to overcome the insulin resistance. So this is important. We have diabetes when there is insulin secretory dysfunction. Insulin resistance usually increases in the second trimester as placental hormogenesis increases. And you remember those hormones we were talking about. The human placental lactogen, prolactin, progesterone, and cortisol. GDM therefore sets in by the 24th to 28th weeks of gestation. We have now data of intervention during even early pregnancy before 24 weeks, and interventions have been done. The EMERGE trial in patients who are of 18 weeks gestation, and showing the same problem of the perinatal complications even in those patients who are having dysglycemia in that gestational weeks. Implications of GDM. As women with GDM are normoglycemic during the first trimester, their babies have a lower risk of developing congenital anomalies, which I showed you the picture. The risk of macrosomia, stillbirth, prematurity, difficult labor, and neonatal metabolic complications are comparable. Okay, that becomes because of the hyperglycemia. Infants of mothers with GDM are again at high risk of developing obesity, metabolic syndrome, and type 2 diabetes later in life. And lastly, women with GDM have high risk of developing type 2 diabetes later in life, and hence the importance of lifestyle modification from day one in this category of patients, and need to emphasize that they are prone for future development of diabetes, and this should be there in their protocol on day-to-day life even after delivery. Now, universal screening, and this is known to us, the high-risk patient population, and this is age more than 25 years, BMI more than 22, and the Asian category. A nice paper was there in BMJ highlighting this aspect, and this summarizes all those. Whom not to screen is given here, but we need to know when to screen. So age more than 25 and BMI more than 22, just 22, imagine, and Asian ethnicity is enough. So we are at the end where we need to go for this screening in all our patients. Indian scenario, all pregnant women should be screened for diabetes. So this is there. Screening for diabetes in pregnancy, and we are all aware of the International Association of Diabetes in Pregnancy Study Group guidelines. Even a single value is sufficient for diagnosis of diabetes, and these are the cutoffs. I somehow don't agree to a single value. I always repeat the test. Any lab can give any result, and I always repeat a test before leveling a patient as gestational diabetes or diabetes for that matter with a single value. So I have found patients who just don't fall in that category. So I will just ask you people, request you people to go for a second test rather than be in a hurry to level a patient as having gestational diabetes. So we come to the management part, the pre-pregnancy counseling, control during pregnancy and post-pregnancy, and these are the crux of management, starting from the pre-pregnancy level. Educate and obtain maximum cooperation from both partners, obtain diabetic control. This is very important before conception because we are well aware of the embryopathy which can be there in diabetics. And a simple impaction won't be there in a hyperglycemic milieu. So we have to have a proper control even beforehand. And the immune status, it is very important. These two things, the immune status against rubella and the optimum use of folic acid even 3 months before planned pregnancy. And we are coming to that area, understanding the risk of perinatal mortality, congenital anomalies in pre-existing ones, and what a diabetic pregnancy involves is very frequent visits, strict acid control. We will see the targets in a subsequent slide, and important, as you can see, the folic acid supplement, and contraception till the patient is having good glycemic control. And this is the treatment target. If you are going for the preconception target, we need to go for a fasting of less than 90. It can be 95. In type 1 diabetes, we can be assured even up to 99. For the 2-hour value, it is 80 to 120. and the 1 hour value is plus 10. So this is just the way I remember. 60 to 90 fasting, up to 95, type 1 99, 2 hours glucose is 80 to 120. For 1 hour value, which is the ADA also proposes, is plus 10 of the 2 hour value, that is 90 to 130, you can go up to 140. So in the fasting you have up to 95, in the 1 hour you have up to 140, and 2 hour 120 is the optimum, less than 120. Continuing with the management, exercise is important and it does impact the outcomes. Upper body resistance training has been shown, but what is important, it has to be undertaken only if it is advised by the gynecologist. Okay, so if they are saying yes, then only we need to emphasize on that. If they ask the patient to go for rest, we need to go for that. The calorie intake, you can see 35 to 45 calorie or 300 kilocalories above the non-pregnant needs. So this is just a bookish thing we don't often require. It is just like going for a diet chart, and majority of my patients, they come up with a diet which is definitely more for what they should be taking. So it is very important to know the background diet of the patient population and then prescribe a diet. For carbohydrate, we do reduce it to 45%. Initially, if you remember, it was to the tune of 50 to 60% or 50 grams of the non-pregnant level. Protein intake is okay, 1 to 2 grams per kg, 20% of the total calorie. 35% is also in collaboration. Iron 27 milligram per day. Folic acid, there is a misprint. It is almost, to remember, it is 0.5 milligram or 500 microgram per day. Calcium, we do require definitely a role of vitamin B12. Glucose monitoring, it's very important part of management in diabetes, and with that strict control of fasting postprandial, you can just imagine how important it is. But for the lab results, this is done by SMBG. For lab results, they have advocated till 28 weeks, once a month, 28 to 32 weeks, because near term, we need to be very vigilant on that. It is once in 2 weeks, and 42 weeks onwards, once a week. And again, I would reiterate, it is nothing to be bookish about. You have to adjust by yourself. This is important, and if you are doing this, practice this. This is one of the indication of initiation of insulin therapy. The increased abdominal girth, if it is more than 75 centile, this is the time where you need to institute therapy, because that is suggestive of future macrosomia. Abdominal circumference more than 75th centile. Now, obstetric management during the first trimester, this is important to take care of all the aspects, including the retina, the renal. The second trimester, again, emphasis on the glycemic control and ultrasound. This is for the major malformations in the first trimester for the viability. So it should be very clear when to go for an ultrasound and for what. So ultrasound in the first trimester for fetal viability and dating and anomalies. Second trimester is mainly for the complications. And then we have the polyhydramnios, which can be there, which can be diagnosed with ultrasound. Third trimester, which is an important part, is the frequent ultrasound for macrosomia. Obstetric management during labor, they do not attempt weight reduction during pregnancy. This is very important. We don't want to have excess weight, but we don't ask to reduce weight further. Diet with 33% calorie restriction is sufficient for obese women. And if you remember the weight gain, it is 16 kg, 11 to 16, and less than 11 kg in patients who are obese, overweight, and underweight. Okay? So exercise program we talked about with the consent of the obstetrician. Insulin requirement, initially it is 0.9 unit per kg, it increases during the second and third trimester, then it plateaus and it dips at the just time of delivery. Approved insulins, Detemer was there, NPH you can easily give, the analogs, boluses are not of a problem, and this was the target we talked about. 90, 120, 1 hour, 2 hour. Most of the patients, they would require even suffice with a single basal insulin and metformin in today's practice. Otherwise, we need to go for a typical basal bolus in patients with type 1, and if the patients are not adequately controlled. Adjustment, we are well knowing. Insulin management during delivery, and this is very simple, and this was what we used to practice. When you used to give glucose, it is 5% glucose, 5 units insulin, and adjusting with the glucose profile. And you have to change the full bottle when you are changing the insulin according to the glycemia. Okay, and the glycemia, you all know, it is just the amount of glucose divided by 100, and that will give the amount of insulin you will be adding to that. Okay, and in that case, you will have to change the drip, because you cannot instill extra insulin in that. Retinopathy may worsen, nephropathy I have talked about, and the successful management, and the prevention part, and was screening, this was in the quiz, but in our population it should be yearly basis. And with your permission, I think a couple of slides. This is the postpartum management. We need to go for assessment at 6 weeks' time. Effective management and follow-up, and lifestyle modification in women with prior GDM can delay or prevent onset of type 2 diabetes in their later life. Now, just to add about metformin, very recent study, as I said, the emerge study, that was the early intervention with metformin in pregnancy to obviate the effects of GDM, and in there they have taken the cutoff at 18 weeks gestation, and the complications were at par in the placebo group. The macrosomia, the preterm birth, and it was impacted with metformin use, which was given up to a dose of 2.5 gram. Another study which we were very apprehensive in the initial period, what will happen in these children at 9 years of age. And these were prepubertal children, and they have shown that there was more of adiponectin and less of leptin in these patients who are just at 9 years of age in these children. Okay, the effect was more in boys. And lastly, the mechanistics of metformin, they have shown it particularly impacts the immunological profile, less the inflammatory profile, because in that study, they have taken the CRP and the cytokines. Cytokines were more impacted, CRP was not. So the mechanism of action of metformin in pregnancy primarily is by diminution of the cytokines, and this imbalance is one of the reasons why in occasional patients we had increased prematurity with metformin use. But this metformin use in PCOS has been linked with less of miscarriages and definitely better pregnancy outcomes in PCOS. And in the patients before pregnancy, definitely there are two recent studies, the use of GLP-1 receptor agonists and the SGLT2 inhibitors. They have been found to have a better pregnancy outcome when these patients were treated beforehand. So thank you all for the patient hearing.
Thank you, Dr. Santosh Kumar Singh, for such elaborate talk. I just want to mention one point with the view of obstetrician, that it is a disease. It is a fetal origin of adult disease, in fact, and it starts from before fetus or embryo is viable. And pancreas starts working at around 10 weeks. And before that, there should be well-controlled maternal blood sugar. And maternal hyperglycemia stimulates fetal pancreas after 10 weeks and insulin secretion. And if at that time it is high, then there is some programming of pancreas in the fetus, and which can develop diabetes at later age. So pre-pregnancy counseling is a must, and whenever a mother is diagnosed diabetes, the management should be done with a diabetologist consultation. And at first antenatal visit, universal screening for diabetes should be done as we do all other screening, and from there we can start metformin safely. And recently I was going through a literature of November 23 that the PP blood sugar should be below 110 to avoid this phenomena. And if it is more than that, we should start metformin. This is what I gathered.
Okay,
and
well taken.
Very nicely you have projected all the facts about gestational diabetes.
Well taken, ma'am. Just two comments. One is my apprehension with the 75 glucose tolerance test at any time of the day. We should be very clear that that it cannot be, because there is a increased glucose excursion because of the link with insulin sensitivity in the afternoon. So it cannot be just any time of the day. If you have taken something which will stimulate the GLP-1, that will impact the afternoon blood glucose because of the elaboration of GLP-1 in the morning. So I don't agree with any time 75 grams glucose, and I would request you all to go for a proper 75 grams glucose. Always repeat the test even if a single fasting value is elevated. Regarding your talk on that, comment on the metformin part, still recommendations are there that you go for lifestyle modification for 2 weeks and then you add metformin. Only in the EMERGE trial, they have done it early. They have gone for metformin and lifestyle from day one, and the other arm was just the typical which we follow. And this was a study. It was not a recommendation. Recommendation is still what we say by the ADA of 120, where we need to institute. And insulin, I would always like to add the, keep in mind the abdominal circumference for even day-to-day practice.
No, definitely insulin should be there. But in cases of PCOD, when patient comes after taking medicines along with metformin, we do continue metformin throughout the pregnancy.
We do, and I always comment on this because we are at ease with metformin even before this concept of metformin in pregnancy came into being. Because we were using in PCOS and there was not much of a problem, and they have seen less of miscarriages in patients with PCOS and the better pregnancy outcomes with metformin. So thank you.
When you diagnose the GDM or the diabetes pregnancy, you must first, I think, treat with the insulin, first choice of treatment. Metformin, although along with metformin or without metformin, has covered all aspects of maternal complication, fetal complication, diabetes pregnancy, GDM treatment, and latest all the things covered by Dr. Santosh. Thank you, sir.
Sir. Only thing is, I would just make a point before Dr. Prasad asks something. Dr. Santi Singh Madam was always eager to have a talk on GDM in your forum, and I somehow couldn't make it. So I think it's a very optimum time to remember ma'am at this dais. So thank you all for the patient.
Sir, one small query for first excellent lecture. We have got so many old oral hypoglycemic agents. We have got new drugs also. So sir, please tell us what are the drugs which are suitable during pregnancy considering old and new?
Okay. The main problem in pregnancy is that we need to have drugs which passes the placenta at the minimum. Okay, that is the main. It is nothing new and old, is because of the PKPD profile, where less hypoglycemia, the mechanism of action, the receptors which they take care of. Here it is important to have drugs where the passage through placenta is least, and glibenclamide is at the top. Okay, in that. There is no doubt regarding the use of glibenclamide in that. But glibenclamide has gone out of favor. The data which we have with glibenclamide, definitely metformin stands definitely much high in that scenario of having macrosomia and the complications. So we don't think of adding even any oral drug except metformin at this juncture in the management. Insulin definitely is the answer. Glibenclamide, if you take one point. Less passage, and this passage through placenta is also there for metformin. And as I said, there are occasional reports of having premature term because of this passage of metformin in the placenta and its effect on the cytokine milieu thereof, which is linked with the imbalance linked with prematurity.
Sir, any new drug like DPP4 and the GLP-1?
Definitely, I told you that study, but it has been shown beforehand. Patients who are on those medicines, they have been found that SGLT2 inhibitors, they scored regarding the pregnancy outcome when the patients were taking SGLT2 vis-a-vis DPP4 inhibitors. That was vis-a-vis gliptins and sulfonylureas. So sulfonylurea was least beneficial, followed by gliptins, and the maximum benefit was there with SGLT2.
But not fully recommended.
Not during pregnancy. No, yeah. Not recommended during pregnancy.
Glyburide is
this was before pregnancy.
Trial. at London, European Society.
So thank you.
Thank you, sir. Thank you, ma'am, and HK Singh, sir, for chairing this session. And it was a wonderful session. It's always wonderful listening to sir and enhancing our knowledge. So I may ask. नहीं अभी आपको पहले वो देंगे तो और दो दे दीजिए हम लोग समय बाद में दे देंगे दोनों सर को भी HK सिंह सर को भी बाद में होगा so sir will give memento to madam. अच्छा बाद में सर लोग को भी So coming to the, thank you sir, thank you ma'am. Coming to the next session. So next session will be given by Dr. Subhash Kumar sir, and to chair the session may I call upon Dr. Adnan Imam and Dr. A.S. Prakash.
We welcome Dr. Subhash Kumar sir in the 11th annual conference of BDF. Subhash sir is well known to all of us. So today's topic is cachexia and obesity, the two sides of same coin. So sir will deliver his talk on this topic.
Good morning. Respected chairpersons, and at the outset I would like to congratulate Team BDF for putting up this enormous conference, and I thank our teacher, mentor, Dr. HK Singh sir, who is our lifetime president of Bihar Diabetic Federation, chairperson Santosh sir, and the person behind the whole show, Dr. E. Haq and Dr. Kunal and whole team, for this BDF is something which gives us feel of our own. Bihar Diabetic, we work together and we learn from each other. And I must thank our teacher Santosh sir for giving me this opportunity to talk on cachexia and obesity, the two sides of same coin. This talk is not about any molecule as such. This gives you an idea about the recent trends which are going now, and the physiology and pathological mechanism where so many different molecules will come in future. And recently we just discussed about UKPDS metformin benefit, and Dr. Shyam Kishore presented regarding SGLT2 weight loss and why DPP-4 not creating a cardiovascular benefit. This is all linked to somewhere about the adiposity, the visceral fat which is there, which cause pathological inflammatory damage to the endothelium, and how this mechanism goes on, and how it helps to understand different molecules and different mechanisms. Obesity and cachexia are both related to change in body composition, but one on opposite side of the spectrum. Obesity refers to excessive fat accumulation, we know that, and imbalance of both calorie and energy expenditure. The amount which we take and we burn it through different mechanism is associated with various health issues which I'm not going to discuss, but we know that CV risks are very high with all other cancers and etc. Cachexia is, on the other hand, is a wasting syndrome characterized by a significant loss of muscle mass and fat tissue, often seen in chronic disease. Either you can take chronic infections, cancers, HIV, heart failure, COPDs and so on, and it results from a complex reduction in calorie intake via inflammatory markers like cytokines and so many other things which I am going to discuss regarding the inflammatory markers. So, what is this phenomena of cachexia and obesity? Thanks to Santosh sir for this, because I learned a lot when I was going through the topic when he gave me last month, and we have certain mechanism which is controlling both end of the spectrum, and understanding of this mechanism makes us much wiser in terms of understanding several molecules which are there and which are going to come in future. This obesity and may result from the imbalance of operation of orexogenic and anorexogenic circuit, which disrupts the homeostatic loop of body weight regulation. Each word is important because we know that there is a feedback mechanism which takes in at the central nervous system, and there are certain peptides, neuropeptides, which either stimulates hunger or suppresses it. That's why we call as orexogenic and anorexogenic circuit. I'll explain it further if you just give me a second and just pay your attention closely. In healthy animals and humans, weight loss is powerful inducer of hunger. Why we say a powerful inducer of hunger? Because when we try to lose weight by our diet and exercise, we tend to recover it as quicker than we lose. Why? Because our body tries to regain it. It understands that we have a system where the calorie is preserved, and that is why adipose tissue secretes a hormone, leptin. You just heard Santosh sir about leptin just before this talk, which has been shown to be an essential element in homeostatic loop that regulates body weight. Whenever you lose weight, then your leptins will be having effect. Leptin acts to control food intake and energy expenditure via neuropeptide effector molecules which is there at hypothalamus. I will tell you how hypothalamus help, and it has a receptors for leptin, and if there is a regulation at leptin level, then we will have an effect on our energy expenditure and food intake. Through neuropeptide effector molecules located in the hypothalamus, leptin regulates the expenditure of the energy. Behavior and metabolism are influenced by the loop. Why? When we try to lose weight, we want to lose weight, or somebody is trying to lose weight, no, you will be forced by these hormones to regain it by taking extra calorie. Your brain will work in such a way that you try to grab more calorie and try to regain whatever weight one has lost. So, it has an intricate interplay between nervous, endocrine and immune system. The other hormone other than leptin which is counter-regulatory is ghrelin, which is a recently identified endogenous orexogenic peptide found in the stomach. The leptin was from the adipose tissue, and this is from the stomach. When your stomach is filled or when your stomach is empty, these ghrelins have its role. Plasma concentration of ghrelin dramatically decrease after meal. What does it mean? That you indicate that it is involved in the short-term regulation of food intake, and ghrelin regulates body weight over the long term through the induction of adiposity. Treatment of cachexia and obesity can be based on these therapy. Leptin has been studied in experimental model for weight loss, but it failed because there are many more things involved in it. Maybe a leptin resistance was one of the things which was thought of. So, the other important aspect of these cachexia and obesity after these neuropeptide is the site of action, that is the hypothalamus, because these both things act at the receptor at hypothalamus, and how it helps hypothalamus by having an appetite regulation. This is the site of regulation where neurons in the arcuate nucleus of the hypothalamus detect hormone signals, both leptin and ghrelin, and these signals help regulate appetite by influencing feeling of hunger and fullness. And it also has a control over metabolic rate through the pituitary, we know, through the thyroxine levels. So, hypothalamus regulate metabolism in influencing also the sympathetic stimulation. And it also has a thermoregulation by which it increases the expenditure of energy. Leptin resistance, which I was just talking, that in condition like obesity, there can be a resistance to leptin where the brain does not respond properly to the hormone signal and leading to continuous feeling of hunger despite. So only many of our people, they keep on asking, sir, every time I eat and I feel hungry, and midnight snacking is because of that. Hypothalamic lesions are also associated with it, either due to whatever pathology, damage to or tumor to these areas can disrupt regulatory function, leading to significant change in appetite, metabolism and body weight. So, in a snapshot, other than leptin and ghrelin, the satiety hormones are insulin, amylin. Peptide YY is very important in that regards, and cholecystokinin, pancreatic polypeptide and GLP-1s. So far we only have GLP-1s which has an effect on satiety. And if you look at the hunger hormone, this is ghrelin which I just talked, and thyroxine has the role on it. To have a central regulation on depending on this is the regulation from the adipose tissue. Leptin stimulates the hypothalamus, which I said, and there is a regulation of appetite, and from the gut we get ghrelin and other polypeptide like peptide YY and GLP-1 and so on, which has a depressive effect on it. So, biological system acts to maintain body weight, and any dysregulation to this can move either on the obesity side or on the cachexia side. So, peptide hormone that influence are importantly discussed here, and there is other mechanism also involved other than neurohormones. There is a gut microbiota regulates to these hormones as well. So, gut, pancreas and adipose tissue, they all are responsible for having the disturbance or balance on these satiety and hunger center of our body. So, I will discuss a bit about homeostatic eating and hedonic eating. Homeostatic eating is something that we eat whenever body needs and there is a hunger to the body, but hedonic eating is eating for pleasure. Know that you have a reward and punishment center in our central nervous system, and when you have this hedonic eating, you derive the pleasure via the signals from dopamine, and that controls the wasting and motivation or drive to eat. And there are opioids and cannabinoid receptor that controls liking and pleasure. So, in spite of having a full stomach, or you have this another mechanism where hedonic eating, and that can this part of hedonic eating can have influence by behavior modification, where your higher center cortex suppresses it and makes you understand and feel that okay, you don't want to eat. And this is how SMBG works actually. How we regulate it? When we do a frequent blood testing, a person sees that his sugar is high, suddenly his appetite, his desire to have extra calorie suppresses. And this is the way that your central nervous system, your higher center helps in terms of reducing it. The other thing, which is the last part of my talk, was the intestinal flora. We know that this is an area of research now. There have been tremendous work in this area. Recently, King's College London has presented a wonderful paper on regards to the effect of microbiota on different disorders, which also include psychological disturbance as well as other whole lot of disorders. And we know that 10 times we have more bacteria than cell. So, we actually are more bacteria than a human, our body, because we carry so many of them and they regulate us. Actually, that is the bigger hormonal regulation center than whatever we have learned so far in terms of hormones which we secrete from different organs. But these bacteria has strong influence. This is the study which I was just talking, that human microbiome and central obesity has a direct study relation, and different gut which has been studied from twins cohorts study, that you can see that if gut microbiota is modulated, it can have impact on different disorder, including adiposity, including other part of it. And how does it help? Just small information that gut microbiota modulates gut-derived peptide YY secretion and as well as GLP-1 secretion, because gut microbiota fermentation of prebiotic promotes L cells differentiation in the proximal colon at experimental rat, and which also increases the GLP-1 response to meal and healthy individual. So these bacteria, they upregulates the GLP-1 receptor at the GLP-1 secreting L cells at the intestine, which can increase or decrease the level of GLP-1 and GLP-2. So it has impact on our obesity or cachexia. So homeostatic eating, I just discussed hedonic and I think this we have gone through. So I'll stop over here because it's more of a biochemical thing, but the important is the correlation of ghrelin and leptin and how does it help at the level of arcuate nucleus, and this is going to come again and again in different mechanism of GLP-1 based therapy or even a gut based therapy, which is going to be future of metabolic disorder. Thank you for patient listening.
Thank you, Subhash sir, for your wonderful talk. And we know whenever the patient comes to our clinic and diagnosed with diabetes, he presented with muscle wasting, significant weight loss, and also has obesity. And you have covered all the things. You have shown us the importance of all the hormones, ghrelin hormone and leptin hormones and other hormones. So my question is that if a patient have a muscle wasting as well as obesity, how will you manage this patient?
Muscle wasting in terms of in the background of diabetes or
in the background of diabetes, yes, yes. And neuropathy.
If it is uncontrolled diabetes, we know the mechanism where the ketosis takes place and how when the insulin deficiency is there. That's why I said that the one of the regulation the appetite regulators are insulin and the energy which is used through the carbohydrate mechanism, it goes to the through the protein mechanism where you get the lysis of all those important proteins, including the muscle fibers. So in such case, I think we should go back and see the pathology, the diagnosis, whether it is type 1 and if it is if it requires insulin or any other metabolic error which is associated like hypothyroidism or any chronic infection, inflammation, any there can be all those inflammatory markers should be looked after if you find that it is there in that patient. But commonly it is insulin which is deficient and which drives the metabolism from glucose centric to the protein centric.
Thank you, sir.
Thank you, sir. It was a very nice talk presented by you, covered mostly all the things that should be needed for this topic. As sir said, I would just like to add one point is like when the patient is having obesity as well as cachexia, as you have already told about all the things, part of behavioral therapy, counseling and a proper lifestyle management with respect to diet changes may help the patient to overcome a part of this with respect to what you have already told. So I think that will be also an important part for managing the diabetes as well. Any questions from the audience will be entertained.
I'll request Santosh sir comment on because I don't know whether I came to the expectation, because this is a topic where it is not discussed so far.
It was definitely a tough topic. Separately, we can definitely do justice talking about obesity, talking about cachexia, but two sides of the same coin is definitely a tough job. Only link, I would say that the basis of these two problems lies in the inflammatory cascade, and just the opposite hormonal imbalance which we have and the energy expenditure which we have. So the different hormones which are propagated in these two conditions are distinctly, both are different. Common is the energy expenditure profile, which definitely goes opposite to that. Inflammation is intrinsic to both. And if you talk about the obesity paradox, We all know that the normal BMI patients are at an advantage, but severe obesity, morbid obesity again is a drawback. Having a lower BMI in the lean category again is a problem. So both these category of patients are prone for having the same problems, be it cardiovascular, be it renal, and the aggravation thereof. So that normal BMI is very important, and this again stems from the same inflammatory cascade which is there. Now regarding gut microbiome, we are now well aware that we do have agents which impact the insulin sensitivity which are released from the gut, and there are agents which are responsible for weight loss. If you remember the lipolytic factor which is there, so the microbial culture in leans and the obese is a bit different. The elaboration of short chain fatty acids which we correlate with acetate and the butyrate, they are always beneficial. But propionic acid, it has its effect on anti-inflammatory agent, but it also has detrimental effects at the level of the brain. So, and this varies between leans and the obese. So if you talk of one thing which explains both these is the inflammation part, and that will explain the two sides of the coin, and major extent linked with the gut microflora, which is again responsible for the different complications. Okay, thank you.
Thank you, sir.
Thank you, sir. Thank you. So may I ask the chairperson to honor our speaker? Thank you. And may I ask Dr. Raj Kamal to come over the dais and honor our chairpersons? इधर अब उनका So thank you, doctor. So over to next session. This next session is very interesting, and to deliver this session, we have a very senior doctor, Dr. Professor Ajay Kumar Sinha sir from NMCH, and to chair the session we have got Dr. H.K. Singh sir and Dr. E.H. sir.
So, without wasting time, I'll just say that generation 2 basal insulin has got a longer duration of action as compared to generation 1 insulin. So it's got very smooth PK/PD profile. And with generation 2, there are less chances of hypoglycemia overall, and especially nocturnal hypoglycemia in special certain situations like old people and patient with cardiovascular disease, renal insufficiency, etc. So to talk about generation 2 basal insulin, we have Dr. Ajay Kumar, and he will start the deliberation.
Thank you, Chairperson. Thank you, VDF team, for arranging a good conference and inviting me as a speaker. Honorable Chief Guest of today's program, Dr. Professor D.K. Srivastava sir, Dr. S.K. Singh sir, Dr. Professor Umasankar Prasad, my professor from PMCH, and all the senior diabetologists and diabetologists of the town, students. Before I start my presentation, let me disclose that nothing new I am going to talk about. It's just the revision of the things which have been covered many times. So my talk will be in 4 parts. The first, I will like to remember to the insulin discoverer. The second, I will talk the new technology of CGM. The third is the role of the basal insulin, which we all know. And the last part, I will cover about the evidence from the RCT or real world evidence about the talk which I am going to deliver. So with this, I start my presentation. We all know well, in spite of the bad news, that the diabetes is growing up. The good news is that many of the countries are showing downward trend. And the other part, we have the more drugs in the armamentarium, and we have many new technology which are emerging, which will help us to bring down the diabetes prevalence and the prevalence of complication. And we will try to avoid those processed food that is, in my mind, is the most important factor which is leading to obesity, which Dr. Subhas just talked about, and that is creating the prevalence of diabetes in a bigger way, particularly in India. So this is the two people I would like to remember. The one is the Professor Dr. Banting, the other is a student. And if you will go through the history of the discovery of the exciting molecule, the insulin, one of the biggest discovery in 20th century, you will feel very, love to go through the history. It is so dramatic. If you have interest in history, go and read the book on discovery of insulin by Michael Blaise. So this gentleman, the Banting, was an orthopedic surgeon. He wanted to do something, but he was not doing well. So while traveling through the train, he got a journal where he read about the discovery of the insulin. And then he approached to his professor, who was in a hurry to go to summer vacation. He asked to give some space in the unknown research institute at that point of time. And he asked some student to help him. And then Banting came in the picture, and with the help of the dogs and many other things. It's very interesting. But we remember the Banting and Best for the discovery of such a big achievement in the 20th century. So then came the insulin that Banting and Best and their team created was considered a rapid-acting insulin, which has got some inherent difficulty to use in type 1 diabetes. This means patients with type 1 diabetes needed several injections each day to manage their blood glucose levels. Long-acting insulin that lower glucose levels more gradually over a longer period were greatly needed. A discovery in 1936 by another doctor made long-acting insulin possible. The name was the Hans Christian Hesdorn. We know the NPH. H is basically based on the name of the discoverer of Hesdorn, who created the other laboratory in the world, the Novo. So he was the doctor who discovered the NPH, and that again was a good discovery at that point of time. So now coming to a few words about the continuous glucose monitor, the new technology which has emerged right now. We know that we have three metrics to have control over the diabetes mellitus. The one is fasting, the another is PP, the third one is HbA1c. After DCCT trial and many other trials, we are now focusing mainly on HbA1c. But new technology has emerged, and this technology has the different word, different language, and which is showing a beneficial effect on the prevention of complication. So the continuous glucose monitoring is a device used for monitoring blood glucose on a continual basis instead of monitoring glucose levels periodically by drawing a drop of blood from a finger. CGMs are used by people who treat their diabetes with insulin. For example, the people with type 1 diabetes, also in type 2 diabetes, or other types of diabetes such as gestational diabetes mellitus, meaning by the CGM has got its role in each and every type of diabetes. A continuous glucose monitoring has three parts, smaller parts, not a bigger parts. A small electrode that is placed under the skin, a transmitter attached with the electrode that sends reading from the electrode to a receiver at regular intervals, about 1 to 15 minutes. A separate receiver like a mobile that shows the glucose levels on a display. There are a variety of types of the devices of continuous glucose monitoring. All are not accepted by the regulatory authority. The currently approved CGMs use an enzymatic technology which reacts with glucose molecule in the body's not vascular compartment but interstitial fluid to generate an electric current that is proportional to glucose concentration. So this is a mechanism of action of this continuous glucose monitoring, which is accepted by the regulatory authority. So this is the device. The cost is around 30 to 40,000. The problem is that whether it will be accepted in our population or not. But as I have, experienced that we have, taken many of the technologies, so maybe in future we will have this technology because of its benefit, particularly in the prevention of complication of diabetes, from diabetes. So continuous glucose monitoring is gaining popularity in the Western world for a variety of reasons. Traditional finger prick testing measures blood glucose levels at only a single point of time. CGM enables users to see blood glucose levels continually as well as trends in blood glucose level over time. CGM is a more convenient compared with the testing, finger prick testing, and less painful than traditional finger pricking. So it is a less painful. That is a good point about this. Now coming to some of the language which we use, and that has become a new metrics in the management of diabetes, is one of the important metrics is glycemic variability. The second HbA1c we are using, and the important one is the TIR, time in range. Now a very hot topic in all of the diabetic conferences across the globe, TIR. There are many other terms. TAR, time above range, TBR, time below range, and many others. CV, coefficient of variation. So there are many other languages which have emerged after the discovery of CGM, and its used in diabetes. Now we have come to know that beyond HbA1c, the GV and TIR, the glycemic variability and TIR, are also key metrics nowadays to support effective diabetes management, particularly in the prevention of complication in high-risk patients, where we are afraid of how many times the sugar goes up and how many times goes down in 24 hours period. That causes some patient who has got the high blood sugar, longer duration, but they have less complication compared with those people who have recently developed diabetes and they develop the complication in a much earlier. So that was a cause of concern. So glycemic variability is a common challenge for people with diabetes, now accepted more than HbA1c. Excessive glycemic variability and suboptimal TIR can significantly impact the lives of people with diabetes, and international guidelines are now recommending that in a high-risk patient at least one has to use the CGM. So CGM provides a wealth of data on glucose variability, including excursions above and below target range, and that's why we have come to about knowing the term, the TIR, TBR, time below range. That is important to know the hypoglycemia, and TAR, time above range, to know how many times the patient sugar went above the normal level, which is recommendation is that one has to keep the blood sugar level in between 70 to 170. So this is the recommendation. So which complement traditional metrics such as HbA1c. Recent guidelines recommend the use of TIR, TBR, and glucose variability to assess glycemic control. Now the advances technology and treatment for diabetes, ATTD 2019. They have started their first conference in 2008, and now at Florence in 2024, they are going to discuss about the newer devices for the betterment of treatment of diabetes and their complications. So that recommends on TIR for different diabetes population. So they have recommendation. So So you see first part that in type 1 and type 2 diabetes mellitus, the greener zone if you see, they recommend that the level 70 to 170, 80, sorry, 70 to 180, more than 70 and less than 180. It should be kept 70% of the time. So in 24 hours period, 17 hours should be that the sugar lies in between that. That is the recommendation. If it is more than that, good. If it is not, it's a bad. And time below range should not be less than 4%, more than 4%. So this is the recommendation. So less than 70 milligram, not more than 4%, and less than 54. Hypoglycemia should not be more than 1%. So this is a general recommendation for using CGM technology in type 1 and type 2 diabetes mellitus. But if you see the high risk patient, you will find the time below range. They have released that yes, the sugar range should be in between 40 to in between 70 to 180. If it is a 50% acceptable, but the hypos time below range should not be more than 1%, and never in 24 hours of time it goes below 54. So because we know the hypoglycemia is one of the greatest risk factor for the increased genesis of the cardiovascular related complication. So that's why they recommend in high risk patient. And if you see the last part, gestational diabetes mellitus, they recommend that the sugar should be more than 90% of time. So it's a recommendation from those people who are devising the CGM and they are recommending. So now we will analyze that what they have recommended, whether this is good based on the RCT or RWE or not. So this is data which says that suboptimal TIR yes. So each 10% drop in time in range was associated with 64% increase in risk of retinopathy in people with type 1 diabetes. So 64% benefit. So if each 10 drop means TIR, if it is more than 70%, good. If it is less than 60%, so there is increase of 64% of increased risk of retinopathy. 25% increase of peripheral neuropathy, 40% increase of microalbuminuria, and there are others. So this has been conclusion of two of the important trials, although the trials were of the brief period, but they have shed some light about the relevance of TIR in the management of diabetes. So this is a B. Mohan recommendation, where to adopt the positioning of time in range in the treatment of diabetes mellitus. I will not go in detail. You will find almost in type 1 diabetes mellitus, type 2 diabetes mellitus, all category of patients, whether they were on the diet and exercise, whether they are on oral anti-diabetic drug, whether they are on oral anti-diabetic with insulin, he has recommended in all category of patient, there is a role of the CGM technology, the TIR technology. Not only in the high-risk people, but as per B. Mohan, he has recommended that the indication for time and range is wide. So in all type of diabetes, we can use the time and range, because that will suggest, if we are on the dietary advices, it will suggest that how much carb you are needed, how much protein you are needed, whether you have to delete some carb or add some protein, so that it will recommend. And in the high-risk patient, it has got the recommendation in a strong way. So now coming to the comparison of the recent basal insulin and the first generation basal insulin. So GLA 300 compared with the first generation basal insulin, what is the relevance in terms of CGM and variability? So the method was 16-week randomized crossover study with 59 type 1 diabetes patients using CGM during the last 2 weeks and each 8 weeks period. And 8 endpoints were GB metrics, mean glucose levels, mean change in HbA1c levels. And what it concluded that GLA 300 improves glycemic variability irrespective of injection timing. So we know that, of course, we advise to take basal insulin preferably at night, but many of the patient has got variability, and variability is shown that it is at around, if we count the time for more than 3 hours, more than 40% of the people are not taking the basal insulin at right point of time. That's why there is a risk of the hypoglycemia. So GLA 300, if this molecule have been prescribed, this injection have been prescribed, it has been found that in spite of the timing taken for the insulin, 300 improves GB irrespective of the injection time. That means what it says that the basal insulin has got effect like peakless insulin, what they are claiming. So there were no such great fluctuation, even if the timing was different from the meal time. So GLA 300 allows flexibility in injection timing to deal with situational variability in day-to-day life. And GLA 300 may allow, this was a study have been done by some of the researcher, and what they have concluded, GLA 300 may allow some flexibility in timing injection to deal with the sustainable situational variability experienced in daily life. So this is a green line, and this is the GLA 300. We'll find the less than 70% and how many times it was. So it was found that GLA 300 was superior in terms of the time in range, achieving the time in range. So that was the recommendation. GLA 300 demonstrate lower nocturnal glycemic variability compared to first generation basal insulin. Now comparing the second generation basal insulin in the light of glycemic variability and time in range based on the RCT and real world evidence which we have. So these are some of the studies, the RCT in type 1 diabetes, RCT in type 2 diabetes mellitus, real world evidence in type 1 diabetes mellitus, randomized control trial in type 2. So there are a lot of studies, PK/PD, pharmacodynamics and pharmacokinetic study. So in range, I will discuss some of the study, what it's saying about the GLA 300. This is a single-centered study. So what it showed that the glycemic variability is not very distinct, but hypoglycemia was a matter of concern. So because of the U300, because of the flexibility of timing, what they have said that there was some, if we were in terms of the clinical relevance, if we analyze deeply, the time will not give me to go to take detail of these things. But what is the gist of that? That for clinical relevance, glycemic variability was not distinct, but the hypo part was important. And to repeat it, that hypo is nowadays dangerous for those patients who is having the chronic type 2 diabetes mellitus, or those patients who has some complication related with the diabetes. So for those patients, we wanted to have some molecule which has got less hypos. And this drug has scored based on some of the studies which I have shown. Again, the further data demonstrating it has been compared with the IDEC 100, the GLA 300 with IDEC 100. Most of the trial have been done comparing the GLA 300 and the popular IDEC 100. And what they have found that in this study, 22% patient has the greater insulin peak with the IDEC 100. So greater peak, more hypos. 23% lesser within days variability with GLA 300 versus IDEC. So these are two different studies which have concluded that the insulin level was at one point of time was more compared with the patient who were taking the GLA 300. So these all are a study which favors the CGM, which favors the GLA 300 based on the CGM technology, not the other technology. So to conclude, the glycemic variability and suboptimal TIR can significantly impact the lives of people with diabetes, which is well proved by some of the smaller studies. Use of CGM is generally associated with an improvement in the hemoglobin HbA1c level and reduction in the risk of hypoglycemia. In numerous trials using CGM and TIR profiles have demonstrated that GLA 300 provides effective and sustainable glycemic control with lower incidence of glycemic variability. The use of GLA 300 right now is associated with lower incidence of overall or nocturnal hypoglycemia. So till today, the GLA is claiming that it is superior than any of the other competitor, the second generation basal insulin. Maybe in future we will have some new molecule which will have some more benefit. But till now, we have, if we want to use basal insulin and in any setup of the type 2 diabetes mellitus, if the cost is not a concern, GLA 300 is a better choice than any other basal insulin which we have in clinical practice. Thank you very much.
Thank you, Dr. Sinha, for a very informative deliberation. You have covered all aspects of diabetes management type 2 with the basal 2 basal insulin. You have also done the comparative study of glargine 300 versus high insulin degludec. And you have covered first the insulin glargine 100 unit per ml and then versus 300 unit glargine per ml. The 300 unit is more beneficial for long lasting control, better management, and insulin degludec is also a very good drug and it is used in type 1 also and in pregnancy also. I am also using in both cases and patients are doing well. So with this, with lack of time, I will close the session. No questions. The question from the house will be dealt in the lunch time. And further, Dr. Santosh Kumar Singh, the presidential oration.
Thank you, sir. Thank you, Ajay sir, for a wonderful talk. So I would like my chairpersons to felicitate the speaker. And may I call upon Dr. Ajoy sir to felicitate our chairpersons. उधर देखिए सर. So the next session is a very interesting session that will be delivered by none other than Dr. Santosh Kumar Singh sir. And to chair the session, may I call upon D.K. Srivastav sir and Uma Shankar Prasad sir.
Good afternoon, everyone. First of all, I thank the organizers for honoring us to chair this prestigious session of presidential oration. The speaker for this oration is a senior endocrinologist and diabetologist of Bihar. He always speaks evidence-based medicine. He always quotes certain trials and always talks in terms of guideline-based medicine. He is none other than our Dr. Santosh Kumar Singh. The topic of this session is precision medicine in diabetes, obesity, and metabolic syndrome. All these three conditions, they are very common in day-to-day practice. They alone or in combination, they are the very important risk factors for the coronary artery disease, stroke, peripheral vascular disease. All of us know that 1 in 10 adult in India, they are diabetic. And 2/3 of diabetics, they are obese. So to highlight all these things, I invite Dr. Santosh Kumar Singh, precision medicine in diabetes, obesity, and metabolic syndrome. Over to sir.
Honorable chairpersons, dear sirs, dear friends, we are in a hurry. You might be getting bored with the same face coming time and again, but this you have to bear. In the presidential oration, you have the liberty of putting your talk to everyone without any questions. So that is an advantage. But this topic was very deliberate, and this I planned even last year where we delivered our talk on type 1 diabetes. And I think it will be very fruitful to all of us. And I think the carry-home message should be what we exactly mean by precision medicine. And this, I am sure it will go through all of you. A very important quote, as you can see. It is more important to know what kind of a patient the disease has than to know what kind of a disease the patient has. So just imagine the scenario. More data does not necessarily mean improved decision making and whether the precision medicine can be used for multifactorial conditions. So this is before this. I think 2023 is the year of precision medicine. We have a whole session devoted to precision medicine in the last ESD. And as you all know, whenever they give talks, they have a concomitant publication in the Lancet or NEGM or whatsoever. And this was there in the ESD, which was held in October of this year. So I would read it between the lines because the couple of initial slides are very important. And as I said, the message should go what we exactly mean by precision medicine. The first paper of the Lancet Diabetes and Endocrine series proposes a novel translational framework that aims to help the process of translating precision medicine into clinically meaningful decisions. There is still confusion over what precision medicine entails. Often, genomic research is seen as the predominant, if not the only component, which can lead to the assumption that precision medicine solely involves costly techniques and technologies that are not yet widely available. And this is not true. We do have now clinical data which aids us in the management of the patients. However, precision medicine can incorporate genetic, environmental, and clinical markers to improve the accuracy at every stage of medical management, and that includes prevention, diagnosis, prediction, treatment, monitoring, and prognosis. This is again the overall thing which we are talking about. Precision medicine emphasizes the whole spectrum, and this particularly entails to subgroup of populations sharing similar characteristics. And this you can easily imagine when we have the clustering in diabetic patients, where we have the clustering in obese individuals having obesity and diabetes as such. So precision medicine focuses on minimizing errors and improving accuracy in medical decisions and health recommendations. So remember this line, I will show you in the next slide. It seeks to maximize efficacy, cost effectiveness, safety, access for those in need, and compliance compared with contemporary evidence-based medicine. So contemporary evidence-based medicine, definitely it's helpful. We, as Dr. Prasad has told about the evidence-based medicine, the benefit we have from that. But this is going a step forward. Precision medicine emphasizes tailoring diagnostics or therapeutics to subgroups of populations sharing similar characteristics. So you can have same type of patients, but we need to be very precise in managing those individuals. This is a bit different from personalized medicine. As you can see on the right hand side, both terms, although they are interchangeably defined, they are definitely, the personal medicine is the final step in the process of translating knowledge into practice. So use of a person's own data to objectively gauge the efficacy, safety and tolerability of therapeutics and subjectively to tailor to his health needs. This is personal medicine to the same patient. Otherwise, it is this group which we are thinking of when we are talking of precision medicine. And this is the thing all of us should remember today. Precision medicine is reducing error and improving health recommendations and medical decisions. I would repeat because this is a definition and we need to remember this. Precision medicine is reducing error and improving health recommendations and medical decisions. Today we have contemporary medicine. The error is definitely high. Lower is the aim of precision medicine. And then we have at the tail end the personalized medicine. And this encompasses all this. Okay, the transcriptome, the genome, proteome, metabolome, and ultimately the phenome which we are dealing with when we are talking of this. And this is an example when we are dealing patients with infertility. And look at the levels which are there. Starting at the top end is the clinical part, patients with male infertility, and the sperm count is deranged. And then you can have the either autoimmunity or endocrine causes in the pathogenesis. And then you are to know what could be the causes. And then you have the proteomics, the transcriptomics, epigenetics, which is again important, and lower down the role of genomics, which is there. So precision medicine is not only genetics. Okay, it encompasses all these, and definitely the future will be dealing with this. This is the time frame of the historical milestone for the development of the precision medicine, and from here you enter what is the favorite today is the involvement of the microbiome. So just have a look at this slide. I won't go into the details of this. Now the importance of drug microbiota interactions and emerging priority. I'll just rush through the slides. Just have an intense look at the slides and how this matters. And the gut microbiome impacting the drug-drug interaction, the adverse effect profile, its benefit on the patient individual, which can all be affected by the change in the gut microbiota. And from here, a simple example when we are talking of precision medicine and the gut microbiota. You start with the genetics, pharmacogenomics, and then you enter the pharmacomicrobials and the role of the pre and probiotics thereof, which can aid in the management of the patient. This is a very busy slide, but you can understand the basis how it can affect the already existing drugs which we have before us. And a few examples. If you take the endocrine system, the role of metformin, GLP-1 receptor agonists, alpha-glucosidase inhibitors, and DPP-4 inhibitors, and their role on changing the microbiota milieu. And by that way, they can affect the different systems in our body. Liraglutide, one of its benefits was possibly linked with the change in gut microflora, including the thing I was mentioning to Subhas, that you can change gut microflora and you can impact obesity. This is again interesting. Statins, we all know it. They are supposedly diabetogenic. The higher the dose, more the diabetogenic potential. But they can impact the gut microflora in a beneficial way, and that can be either way. They can act on the pregnancy X receptor in the gut microflora, which can be detrimental. Otherwise, there are beneficial change in the gut microflora where they can have a beneficial effect in the glycemic control. Same applies for ACE inhibitors and the warfarin, which we are well aware of. So multi-omics, and that's the journey of different omics and the patient management. Now we come to our area of the concept which we started with the precision medicine. The clustering of diabetes, this was a very new thing which was proposed by this group, Alkevist. These are the different types we are well aware of. Severe autoimmune diabetes, severe insulin deficient diabetes, insulin resistance diabetes, and the baseline, the control is the mild obesity related diabetes and mild age related diabetes. So when you come across these terms, don't have this impression that mild means they are not having complications. This mild terminology stems from the differences in the beta cell function and insulin resistance. Okay, so this should be very clear. When we are thinking of mild obesity related diabetes, I will just show in the next slide why it is mild, because that just deals with the insulin secretion, beta cell function and insulin resistance. This is it. Okay, when you are categorizing patients, definitely GAD, and that will be leading to the severe autoimmune type. So that is a distinct area. If you talk of type 2, it is severe insulin deficiency, that is denoted by the HOMA B. If it is less than 50, it is suggestive of severe insulin deficiency, and HOMA IR, if it is more than 2.5 or 3, it is suggestive of severe insulin resistance. If the patient is not falling in this category, okay, then you are dealing with either mild obesity related diabetes or the age related diabetes. In the obesity part, if the BMI is more than 30, that is mild obesity related diabetes. Okay, and the age related diabetes is just the higher age group which they can have, and in those category of patients the BMI is less than 30. So be very clear about this categorization of the clustering. So you want to see for the GAD antibody, separate type 1, type 2, and in type 2 you have the HOMA B for beta cell function and HOMA IR for insulin resistance, 2.5 and less than 50. In my own series from East India, along with my friend Shailendra from BHU, we had this, and interestingly you will be able to know that almost only 6% patients were typical of mild obesity related diabetes. 24% were typical insulin resistance diabetic, and 42% patients were only severe insulin deficiency, and insulin deficiency with SERD, which is again reported by V. Mohan Center, it was the other 24% category. So 6%, 24, SERD, 24 is the combination of the two, and maximally was severe insulin deficiency diabetes. It was prevalent in 40%. So in our patient population, definitely we are having more patients who are having significant insulin secretory dysfunction. These are the different phenotypes which we have, just to highlight that even there are categorization according to uric acid, and this is a very important marker. Insulin resistance is linked with increased uric acid. Hyperinsulinemia is linked with increased uric acid. Hypoinsulinemia again is just the reverse. It is linked with insulin deficiency. So this is one way where even diabetes has been linked with uric acid, and I will show you in my second last slide. These are again different types of clustering, and this entails C-peptide and HDL cholesterol. This is not HOMA B and HOMA IR. This is extra. They have taken as C-peptide as the cutoff and the HDL cholesterol. And from this you have this very clinical one. In the insulin deficiency you have the higher age group, the BMI is in the mild obesity diabetes, insulin deficient is the SIDD, and then you have the SERD in the mild age related. You have either with normal HDL or high HDL. Okay, so that is the basic distinction. And look at this interesting aspect. There is similarity and differences in these clusters according to the proteomics and the genes which are being shared with the typical insulin resistance. So even this mild age-related diabetes with increased HDL, they share the same genes which are responsible for kidney function decline and more of a cardiovascular problem, which we always apprehend with the SIRD, insulin resistant diabetic. Now we come to the treatment part, and just have a look with this, the agents which have been tried. Definitely in insulin deficiency, it will be the agents